That always helped my eyes. I don't know.
Let me turn off my volume, please. Let me turn off my.
I'll give it just about a minute to let everyone in, and then I'll start the introductions. Welcome everyone. We are about to get started. My name is Drew Summerer. I am a board member with OPA, and I'm just going to kind of go over a couple of housekeeping items before I introduce our presenters. First of all, we will be recording this presentation, and so we ask that everyone please mute your microphones. Otherwise, you will show up on our lovely recording, and I don't know if you want to present today. Secondly, I'll be taking, if you have questions throughout the presentation, please put them into the chat feature. I will be trying the best I can to get on any of the questions that we have. Please be as clear as you can with your questions so I can ask them exactly how you would like them. And then as far as getting the CE credits after the presentation, we will be sending out a survey, but that survey will ask for a verification code. I will be giving the verification code about 5 minutes before the presentation ends. Please write that verification code down. I'll put it in the chat. I'll try to make sure it is as visible as possible so everyone can get that. But the survey will ask for the verification code to put in, and that will be required and needed for the CE credits. I guess, yeah, with that, we'll start with our presentation, Suicide Risk Assessment and Prevention, Developing an Evidence-Based Suicide Risk Formulation. And I will just quick introduce our presenters. Heather Ann Delicato, Dr. I, has over 11 years of experience as a psychologist and has served in numerous and varied roles, including clinical consultant, community leader, integrated health and wellness coach, supervisor, and leader in diverse agencies providing services to Indigenous, rural and remote, LGBTQIA+, and SMI populations. She is currently the Military Sexual Trauma Coordinator for the Fort Harrison, Montana VA. Prior to this role, she was an assistant professor of psychiatry at the Geisel School of Medicine at Dartmouth and chief psychologist at New Hampshire Hospital. Dr. I is the former lead of the Zero Suicide Implementation Team at the Suhutsui Medical Center on the Navajo Reservation. The team was distinguished as a national leader in providing culturally informed, safe suicide practices. Dr. I worked side by side with traditional practitioners and community partners to adopt the Zero Suicide Initiative, which led to the development and delivery of culturally relevant care tools, including crisis and emergency response services across remote areas of the reservation. Dr. I cultivated meaningful collaborations with people with lived experience to create post-vention efforts tailored to school, law enforcement agencies, community mental health providers, and tribal leaders. She is a certified psychological autopsy investigator by the American Association of Suicidology. Dr. I was also invited to participate as a leader participant in APA's Leadership Institute for Women in Psychology, 2021 through 2022. Her work is focused on evidence-based, evidence-informed, culturally relevant suicide prevention practices and behavioral health approaches with marginalized and underserved communities. Julie Collar is a clinical psychologist, researcher, consultant, coach, speaker, and trainer with expertise in increasing access to evidence-based psychotherapies to underserved populations via video telehealth and technology. In the past, she implemented DBT, CAMS, CBT, SP, and other evidence-informed interventions in populations ranging from young adults to older adults. She received advanced training in delivering evidence-based practices via video telehealth and specialty telehealth clinical teams, and conducted the health service research and development at the Veterans Affairs in Portland. She most recently was the evidence-based psychotherapy coordinator at Veterans Affairs Southern Oregon. Currently, she has a telehealth practice serving ambitious adult professionals to feel empowered to effectively meet life's challenges in a manner aligned with their goals and values. She's published research on integrated health and chronic pain management, transdiagnostic mechanisms, PTSD, and coping with loss. We are, I think, all very excited to have both of our presenters here. And with that, I will hand it over to them. Thank you.
Thank you, Drew. We are very excited to be here today. Good morning, everyone, and welcome to Suicide. Well, let me try if this works. Welcome to our Suicide Risk Assessment and Prevention training today. I'm Dr. Julie Kaler. Today, please call me Dr. Julie. But if you see me in public, feel free to call me Julie as colleagues. And I just wanted to thank you for the introduction, Drew. I wanted to add that today I wanted to introduce Dr. I because I'm part of the OPA, I'm a volunteer for part of the OPA CE committee. And I have no other conflicts of interest to declare, but I wanted to bring Dr. I with us today because I'm more expert and have more expertise in evidence-based psychotherapy. So that's what I'll be my role today. And then Dr. I is our expert on suicide today. So, which is why I invited her to come and talk with us and share her expertise. So I'll hand it over to Dr. I. Thanks for being here today.
Thanks and welcome to everyone. And I'm also very excited for this presentation and to work with Dr. Julie because I've worked mostly in public healthcare systems, and Dr. Julie also brings the private practitioner's perspective. And so we thought that this would be a good collaboration and presentation for you. Just as a reminder, well, first, I have no conflicts of interest. And while I work for the VA right now, I'm not here in that capacity. I'm here as a consultant, a trainer, and a person who's passionate about preventing suicide. And we also just want to remind everyone to take care of yourself today. This is a sensitive topic. I was reading a report that just came out that said that three out of 5 adults have known someone that has either attempted suicide, died by suicide, or at least expressed significant thoughts or serious thoughts with intentions of suicide. And that's a national number. And so we just invite you to take a step out, or to step away rather, if you need a break, or we have built in some breaks, but we're just inviting you to really take care of yourselves today with this topic.
And with that, today we want to, so thanks, Dr. I, really excited. That's a good point. My why is, right, I'm an independent practitioner, and it's kind of like lonely and unclear what you're supposed to do sometimes, especially around suicide risk or assessment. So thanks, Dr. I. Today we wanted to start by asking participants to type their workplace setting and stage of career or years in the field. We want to get an idea of who our audience is today. So do you work in an ER? Do you outpatient, residential, inpatient? If you could type it in the chat. We're really excited for audience participation today, so we can get a sense of who's here, and maybe we can gear our presentation toward. Okay, so we're noticing some inpatient, private practice, lots of, oh wow, 11 years, integrated care, PCMHI, relationships, 6 years license, private practice. Okay, got a lot of integrated health care, behavioral. Wow, pediatric testing, school psychologists, retired from hospital-based, forensic. Wow, lots of different settings. Okay. And as everyone's finishing typing up where they're at, oh, juvenile, okay, private practice, forensic, ooh, multidisciplinary outpatient behavioral health clinic, the clock talk, social support. Wow. So early childhood clinic, interesting. Well, this might be a little more geared. We'll cover both adolescent and adults. We might be gearing a little more towards adults today. And then another neuropsychological assessment. Well, welcome everyone. We're so excited to have you here today. You all have lots of years of experience. I'm sure you'll be teaching us a lot of stuff today. Our second poll question is, how would you describe your experience working with individuals with suicidality? So you can either just write it in, or you could use a Likert scale, like 0 to 5, 0, not at all experienced, 5, very experienced. How would you describe your experience with um, with working with individuals experiencing suicidality? Extensively, we've got some middle numbers. Oh, we got a 6 above a 5. Wow, lots of really experienced people, it looks like today. But also we've got our great bell curve. So we've got some normal distribution going on in terms of some people at both ends of the curve. So that's exciting. Thank you all for answering and participating. Ooh, crisis line, awesome. Anxiety invoking. It is anxiety invoking, and that's why we're doing this presentation today, because we don't want anyone to feel alone. So I'm going to switch the slide to this one. And then our second poll question is, what do you hope to learn today? Is there something specific that you all were coming in hoping to learn today? Outpatient behavioral health department and most multidisciplinary medical practice, providing adult psychotherapy, 11 years. Wow. And then 10 years in university counseling centers. Oh, I worked in university counseling centers. Those ones are hard. Lots of risk there that you're doing. Limited experience with clients experiencing suicidality. Best practice, nice. Assessment of risk and creating safety plan, documentation guidelines. Oh, we're going to touch on those. Update to culturally informed practices. Yes, Dr. I and I are going to touch on that. Anything specific to Oregon about dealing with suicide? Ooh. We'll have to see if we have something about that. Support younger children, social support. Get staff to do assessments, formulation of risk. Okay, so looking for people dealing with suicidality that's atypical with autism. I'm not sure. The one thing we weren't able to have, we have a lot of content to go over, so I'm going to jump in. We weren't able to have the role of shame and suicidality, right? So we're going to talk about a chain analysis today. Great. Assisted suicide. Oh, yeah. So I worked on some projects where we did the Oregon Death with Dignity. We were looking at some interviews, trauma-sensitive ways to respond to persistent suicidality. We're definitely going to talk about that. Okay, so it looks like we're covering some things that people are looking for. Please ask us questions if we are not covering something or if we missed something. I'm going to move to the next slide. Thank you all for, we'll talk a little bit more about some of these topics throughout, but please ask questions. I think Dr. I was, had mentioned this slide already, or did you have more to say on this?
No, I think just that we're gonna probably take more questions at the end, and we have built in some mini breaks. So we'll let you know as we go.
Okay, and
so we included this because Camus was the first philosopher that really struggled or wrestled with the idea or the notion of suicide. And in his essay, he suggested that suicide amounts to a confession that life's not worth living. And I wanted to just mention, and I don't work for these people and I don't make any money off of any of this, but there's a more contemporary philosopher, and some of you may have heard of him, Clancy Martin. He wrote a book called How Not to Kill Yourself, A Portrait of a Suicidal Mind. It's actually a memoir. And he's an attempt survivor, multiple attempt survivor. And Terry Gross on NPR did a really interesting interview with him. So I'm not plugging his book per se, but he's a contemporary philosopher that addresses his own suicidality, and he talks to his students about it. So because he's a professor of philosophy. So I just wanted to mention that. Clancy Martin also talks about an attempt survivor having a superpower, because he says he understands what it's like to be suffering in a way, and that the person is now in a position to help others going through something similar. And so I just thought that that was really profound, and I wanted to share Clancy Martin with you guys today.
Oh, what a great resource.
Mhm.
Right, and then you know, Camus, right, says we must imagine Sisyphus's life is meaningful. As we talk into the existential grit and the philosophical implications of this. So we've already introduced ourselves and done the conflicts of interest. Today, today's learning objectives include 2 risk assessment strategies, and we'll discuss evidence-based approaches to incorporate into an evidence-based risk assessment. And we'll be breaking out into groups and participating in a case formulation for the last hour together, doing some practice. Oh, am I writing on the screen somehow? I don't know if
I don't
that's
know how
me.
that ended up there.
I
Oh,
hope
well.
it moves. I hope it moves in the next slide. Okay. Comes up. Did it? Okay, hold on. Let's go back.
Those weird drawings have appeared, but I can ignore them and talk, but that is so strange. They just like suddenly appeared on the, oh well. So I just wanted to briefly, because we have so much, we've packed in a lot today. Everybody has these terms and these definitions, but we need to be sort of utilizing a shared language around suicide. There's often, and many of you have probably heard terms, we don't really use them as much anymore, but when people are reporting suicidality, or clinicians, and they're saying, oh, that person is making a gesture, or there are many terms, but for today, we just wanted to just break it down in a way. So when we talk about suicide, we are saying that's a death that has resulted from an action, that someone has taken an action with the intent or the reasonable expectation that the action will result in their death. And so the aim is to die. And there are, in our field, we talk about ideation. So those are beliefs or thoughts, behaviors, and intent, the desire, the aim to die. And sometimes you'll hear me and maybe Dr. Julie refer to like a broader term of suicidality. While that's not specific, we just sort of talk about that. We can go to the next slide too for time. And we'll also interchangeably, just for time's sake, be using, the words patient or client. So whatever your orientation is, just forgive us, but we're just going to use those terms somewhat interchangeably. And then we wanted to give you a reference to sort of discern, differentiate between acute and chronic risk, which we will talk about more specifically today, to discuss risk factors, and to discuss warning signs. So warning signs are more indicative of something imminent or something that could occur I think about it like that. That's when the red flags go off, kind of thing. Risk factors can be chronic, they can be non-modifiable, modifiable. We also talk about protective factors. What are some buffers to suicidality? And those nowadays are not just sort of interpersonal or individualistic. We're thinking about them in a broader, bigger way. Community-based preventions, because suicide is considered a public health problem. And so public health approaches have been getting a lot of play with preventing of suicide. And then identifying reasons for living is also something to consider. Sorry about the X's on the screens. That's really weird. We can go to the next slide.
Trying to figure out how to get rid of that, but it's not happening. So, okay. Did you mention this one already?
No, sorry. Okay. This one is, so the American Association of Suicidology provides recommendations. They're a fantastic resource. I'm sure you guys have heard of them. And they provide recommendations to media for how to report or how to talk about suicide. because it's really important. For example, one of their recommendations is not to give specific details about the methods that were used throughout the suicide attempt or the suicide, just the suicide. And so I wanted to make a brief list for you today, because often a lot of people do say completed or committed, and we have a lack of words around it. So it is hard to talk about or to write about. However, and we're not the word police today or ever, but I just wanted to present this to you because in suicidology, we aren't really using committed or completed. There are some implications to those words, as if there was a goal or if there was something that was successful or not successful. And there are a lot of connotations with that, and it's pretty outdated. Again, we still use it, some people do, but it's not as up to date or preferred, and it's potentially stigmatizing, because if somebody failed at something or committed, there's just something very like pejorative and judgmental around that language. And as we know, language is really critical to how we talk about suicide. So more appropriately, we are saying died by suicide, ended her life by suicide, made a non-fatal attempt at suicide, or attempted or suicided. So I just wanted to bring that up. If you ever want to reference the resources for this, because they're pretty extensive, American Association of Suicidology's homepage offers some really good resources. You can do the next slide.
And we put all the links on the top of the slide so that you can click on them and follow along. And we want to make sure you had all the resources at your disposal. So suicide's a leading cause of death. The suicide rate decreased worldwide over the past 15 years. However, it increased in the United States by an average of 1.5% per year so about 30% across states between 1999 and 2016. And so we're seeing that death by suicide in US adults increased over the first 2 decades of the 21st century. And based on this trend, suicide is now the 10th leading cause of death in the US overall. For children ages 10 to 15, so these are ages 10 to 15, it's the second leading cause of death. And for adolescents and young adults, it's the third leading cause of death. So this is a very serious and important topic, which is why we're holding this training, which is why you are all attending today. And our suicide prediction tools tend to focus on one of 3 kind of overlapping high-risk populations that we study. So either patients in the ER that are coming with suicidal intent or after a suicide attempt, psychiatric patients during hospitalization, and then that first week after discharge, where there's really high risk, significantly higher risk, and then that 4 months to 14 months where there's also high risk after. And so we have more knowledge than ever about risk factors contributing factors to suicide. However, national trends are still changing. We're seeing that men are more likely to die by suicide than females, and American Indian, Alaskan Native, and white race ethnicities have the highest rates above other races and ethnicities, with races increasing more recently for white older adult men over the age of 65. And more than half of all adult suicide deaths in 2021 were due to firearms. So firearms they can increase like tenfold the chance of having a firearm-related accident or injury, just having it in your house. And we're seeing with firearms, 90% of firearm attempts are fatal. So males are more likely to use firearms and suffocation, and females are more likely to die by firearm suffocation and drug poisoning. So still firearms, right? The number accounts for about 55% of all suicide deaths last year. When we talk today, we're going to talk about non-suicidal self-injury, self-directed violence, self-harm. There's lots of different terms in the literature. We might use them interchangeably. The CDC estimates rates of non-fatal self-harm, that's another term, from ER departments. However, this data combines suicide attempts and self-harm without intent to die. So we have both suicide attempts and self-harm without intent to die kind of like combined together with these CDC data numbers. So it kind of muddies the clinical data we have. And we'll discuss this a little bit more later when we talk about CPGs. I'll try not to nerd out too much, but no guarantees. And it impacts the quality of our interventions, right? If we, with these measurement difficulties, we're not really sure what are we measuring and are we choosing the right instruments or interventions to address them. So females have higher rates of self-harm or non-suicidal self-injury than males. And the highest rates of non-fatal self-harm are highest in adults over the age of 30. Or under the age of 30, sorry, under the age of 30, and it starts decreasing as you get over the age of 30. So what means do people use to self-harm? So 50% of non-fatal self-harm involved poisoning. Cutting or piercing was the second most common. And there was more frequent use of self-poisoning and non-fatal events among females than males. And interestingly, even with around 2022 veterans dying of suicide a day, still we have inconclusive findings about these unique risk factors for veterans versus non-military. So we're having difficulty predicting risk or death by suicide. The poisoning, yeah, right. This is why we're telling, right? So we're still having these inconclusive findings about unique risk factors. And difficulty predicting risk or death by suicide from these epidemiological risk factors or specific populations. However, they're really important to know. So what I'm asking you all to do right now, I'm kind of like a hint. I want you all to note these factors for when we do our risk formulation later. So we're going to be looking at non-modifiable risk factors such as age, gender, race, ethnicity. And then we're going to look at assessment for access to means and past self-harm. So kind of thinking, oh, okay, so what tend to be those means for which demographics? And we might consider as part of our risk formulation that we're going to discuss in the second half of today that self-harm might be functioning as relief from emotional distress, potentially. We will do a functional analysis to assess. So ensuring you're assessing the likelihood of impulsivity, engagement with risky impulsive behaviors, emotional dysregulation, and past self-harm severity. We really want to look at that for risk of accidental death from self-harm. And so if there's a higher risk given these factors, we'll need to attend more to the suicidal ideation intention. So is it morbid cognition? Is it more passive? Is it more active? And the prompting or antecedent activating events for the suicidal ideation. But we'll talk more about this later when we do the chain analysis. But want you to remember what types of means of death for suicide by men and women for self-harm, which help guide mean reduction counseling later. And then for the safety plan and chain analysis, we're going to do the functional analysis of self-directed violence. We're looking at things that are modifiable. Reinforcers for self-harm. Can we change consequences or other contingencies to break the chain and create a new chain that actually meets or addresses that underlying need or function in a healthier way? Like for instance, we could assess warning signs and then engage in contingency planning. So, right, like contingency planning. When this happens, like when my heart starts racing and my jaw clenches and my chest gets tight, then I will engage in my coping plan, right? And have that if then contingency planning to hold in mind during your safety plan. So I just wanted to kind of put that on top of your minds to think of today as hold it in your minds as we do that risk formulation, because it's the data we're going to use.
Okay, so this is obviously that there's a giveaway here because I'm calling it Mythbusters. But if you have any thoughts or you want to put anything in the chat while we do these, the first one that I present to people is a myth, obviously, but all psychologists are trained in suicide risk assessment and prevention. If you want to put in the chat what your thoughts are, if you have any thoughts about this, or if you yourself have had to seek additional, more specific training. Someone had typed CAMS into the chat, and I think they have excellent training, and there are some free training, other kinds of training out there. But do you think all psychologists are trained in what we're talking about today? And I'll let the chat go while I talk, because the answer is no, they're not. And I know for myself, during graduate school, the training and risk assessment specific to suicide was really lackluster. It was sort of like, well, you're gonna have to deal with that. So here's maybe one like EBP tool that we use, or you learned it more like during your externships or your rotations, whatever. But it really didn't seem to be enough. And my interest was working with SMI initially. And so I dealt with it pretty quickly in my training. And I was really amazed at the paucity of training that was sort of present or available at the time when I was in school. And so I kind of tasked myself with trying to keep up with current trends or patterns of things that are potentially really helpful with training. And like somebody just wrote, all my training was after graduate school, and a lot of people can relate to that. So Washington State was the first state that required all licensed general medical and behavioral health professionals to complete training in suicide assessment, management, and treatment. And that was around 2018-ish. And I don't have all the current numbers, but it's something like only 11 to like 15 states right now are actually requiring that any kind of suicide prevention or risk assessment training is included in their professional licensure, the trajectory of obtaining their license. There are a handful of states where it's just recommended. I'm actually in one of those, Montana, but I'm licensed in New York, so it's a bit different. Nonetheless, it's changing across the country more and more. We are licensing bodies and accreditation standards are requiring or asking that be part of a bigger plan for the state. And the thing that I want to highlight with this is that medical professionals, not just psychologists, not just behavioral health folks, have a really huge opportunity to help prevent suicide, because, and we will get into this later, but over 40%, the number changes, it's 42, 45% of individuals that have died by suicide have seen a medical health professional within 30 days. And that number is always astonishing to me, that data point, because those are opportunities that we're missing. Those are spaces in which patients are falling through the cracks. And so it really needs to be more of a systemic effort. But I just wanted to highlight that there's basically a lack of training and training standards. Also, the trainings tend to be focused on gatekeeper trainings and things that aren't more specific to clinical. So national standards are requesting or encouraging of a more tiered training approach. We can go to the next slide because I could talk forever about that. And so this is another myth. Often there's this sort of fatalistic perspective for folks, likely not us in this room today, but some people that are, I'll tell them, we do have opportunities to intervene, and suicide can be preventable. And there are some people that have sort of a mindset that's more fatalistic, like, well, if someone's going to do something, they're going to do it, right? But that is absolutely, I guess, not the most feasible, or not the most, I don't want to say appropriate, but it's not the stance that I would ever take, being in this field and doing the work that I've done, or the work that we all do in this room. Because if we have there are so many implications if we aren't holding hope for the people that we treat or that we see. And it's just, when we think about it in context of the medical comment that I made, only about 1/3 of individuals that have died by suicide have even had a contact with behavioral health professionals. So it is absolutely preventable, but it has to also be in a systems-wide kind of approach.
And some recent studies in 2017, 2018 have suggested that our current suicide screens and assessment tools and the majority of cases that are classified as at risk are false positives. And so, as Dr. I was saying, we've got good suicide prediction models that are accurate at classification. Like, most people will not commit suicide, and most of them are accurately classified as such, but we have really poor accuracy in predicting future suicide events. So as among those that are classified as at-risk designation in our current algorithms, only be correct about 1% of the time. So that begs the question, if most cases are classified as at risk, are false positives, then what intervention should we use for false positive or for at-risk cases? And most importantly, like Dr. I was saying, like, can we actually predict suicide? And is that an appropriate goal given this data? And it's a EBP risk assessment and understanding context. I will talk about that more later.
This is another one that comes up a lot because I've done a lot of consulting to systems, especially behavioral health clinics. And we know we have to ask about suicide, and research indicates, or the literature indicates rather, that we have to ask pretty explicitly about suicide. But I have worked with teams that are hesitant to continue to ask. And so we know that people are, we're all complicated and things change in our lives. They're not constant. So risk changes, and it doesn't just follow a linear trajectory. And so I think we have to be sensitive to that. But I have struggled, especially with some inpatient teams, like, will I ask, do we have to ask about suicide, with each shift change? And it's really for organizations to decide. There's no one fit. But it absolutely doesn't. I think that if we hold it in mind that it's going to ruin rapport, or like it's going to push people away, it kind of furthers that myth that we shouldn't be talking about it. And back to Clancy Martin, I mean, he's a philosophy professor, and he normalizes it from day one with his classes. Like, we have to start normalizing the conversation around suicide. And I don't know if anyone has any thoughts about this, but it's really important to not hold that belief that I'm just going to ruin rapport if I keep asking about it. There's different ways to ask about it, but we have to have some kind of sustainable conversation that's not alarming, that's more normalized. And I wanted to put something in the chat really quickly. So I could spend all day on this slide, but I just wanted to quickly go over risk and protective factors. So all of us have some risk and protective factors in mind, I'm sure. But just to give you a little bit more in depth with this, we have with psychological autopsies, we're garnering data post-mortem. So we're asking friends and if you're familiar with psych autopsies, we're asking friends and family that were close to the decedent within 2 to 3 weeks around that time of the suicide, if they noticed any changes. And that information leads into these risk factors that we gather, but many of them don't tell enough of the story. So they offer demographic information or something chronic. They're often clumped together when systems are approaching risk assessment and formulation. They're often clumping them together: chronic, acute, dynamic, modifiable, non-modifiable. And we're not paying enough attention to the more fluid kind of factors, or the tipping points, things that for that person, that individual, could tip them over, the things that they haven't managed well before, or they don't have enough capacity to do, which we're going to keep getting into. We also talk about high risk groups that are disproportionately impacted by suicide. And it's really important, I think, to remember that these groups are not monolithic. So, for example, with Indigenous communities that I've worked with, we don't say, all Indigenous people are at high risk, because that's not true. There are tribes that have zero suicide. There are tribes such as the Navajo Nation, where I worked. the elderly, so age 60 to 65 and over, no suicides. But the youth and the teenagers and the young adults are 4 to 6 times higher than their same age group that are non-native or non-Navajo. And then it becomes even higher when they live on the reservation. So the contrast is stark, and I think we just have to be careful about how we talk about that. It's not a monolithic group. We have to consider social, economic factors. You may have heard of deaths of despair, which I won't get into, genetic. We have to consider lethal means. Most Americans aren't aware of the relationship between lethal means and suicide. And we are also not aware of the relationship between suicide and homicide. That's getting a lot of play in suicidology right now, with discourse with professionals. And Joyner also wrote a book recently about that, because we're not doing a good enough job assessing for homicide, and there's a relationship there. So just keeping in mind with risk factors that there are negative social determinants of health, such as poverty, discrimination, unemployment, and a big one is lack of access to equitable care. We have to also consider mental illness and mental health conditions. And let's see, proximity to suicide and death. That's another big one. So I'll get into it with the collaborative safety plan, but asking about family history is helpful. But for teens and young adults, we want to know proximity to a peer that may have died by suicide. And it doesn't mean that they were best friends with this person. It could be an online relationship. Like, those are also important, and we don't consider those sometimes. They're not always mentioned in the literature. And considering time, so time passing since an attempt is a critical determinant. The first and second year of someone making an attempt, the first year, the first week, obviously, and then there are certain kind of time parameters. Most of the research designates like a month, 3 months, 6 months, and then a year, 2 years. But it's estimated that 1% die by suicide within a year of the first attempt. And so the temporal reality of things is real, and it's important. And also to have hope, back to hope. It's important to remember that 90% of suicide attempt survivors will not die of suicide. So it doesn't mean they tried once that it's sort of, they're going to try it again, or it doesn't mean that. It means that they tried. And something that's protective is also to view seeking therapy as a sign of strength. That just came out in a study of perceptions about Americans and suicide, that seeking help with a therapist or mental health provider could be not construed as weak, that it actually takes courage and it's brave. And the superpower that Clancy Martin talked about is that after an attempt survivor is back on steady ground, that they may have learned something, or they may help somebody else, that they may have a way to language that experience or the phenomenon of that attempt. And that what have you learned, or, well, you're here today. And what do you make of that? And those are kinds of clinical questions that I've asked people. For time's sake, we can go to the next slide. Yeah, so it's complicated. So we don't have much time, but we did want to have just a couple theories on here. And we want to highlight, obviously, Joyner's theory, the interpersonal theory of suicide, in which there are, sure, everybody's familiar with that one, but if you're not, it's critical. And if we have time, I have an actual case of someone who died by suicide, and I later mapped it out with a trainee, and we were sitting in a meeting, and it literally followed the sort of formulation that Joyner presents, with capability for suicide, the thwarted belongingness, perceived burdensomeness, the desire to die, and then access to lethal means. And this case, I guess I'm already talking about it, but it was somebody who worked on the reservation, and he was Navajo, and he was living in this very remote part of the reservation. And he had been talking about suicide to his coworkers for, I think, over a year. And so I was trying to not just work with him, but also to work with their team, like to understand like how that plays out in the workplace. It's pretty tricky considering where we were and the location and the group of people that I was working with. But it was just really tough. And someone wrote shame earlier in the chat, and there was a lot of shame there. People felt very responsible for that. And we did a lot of postvention work that was really helpful, but it was just it was a really sad situation. But anyway, the theories, most of these are synergistic. A lot of these argue for more integrative models over any kind of individual theory of suicide. They've clarified individual variations in longer term vulnerability or risk factor predisposition, and the proximal and moderating factors intercepting and influencing the process of ideation to action. So I'm not going to get into each theory because of time, but I will say this. Often our bias is sort of to the people that are more explicit. And so often you'll hear people say active and passive, and those terms are still used, but I would argue that they're not rich enough. They're not giving enough of the story. And we don't want to be reductionistic in our risk formulations. And so when someone tells me, well, he's not actively suicidal, and I will ask them, well, what does that mean to you? Because research has shown, and if anybody knows Lanny Bergman's work out of Hopkins, he has long ago sort of posited like these people that are sort of quietly suffering, that have intense ideation of suicide, that are frequently experiencing thoughts of suicide, and there's a component of uncontrollability about it. Like if you ask somebody, do you feel like you can push those thoughts away, or how do you handle those thoughts? Are they manageable or controllable? And if the answer is no, they are not. I feel I can't control them. I feel they're going to overwhelm me. Those are just as high of risk, if not more, than someone that shows up in a clinic and reports current suicidal thoughts. And so often I think our bias is that the person, sort of the louder or the more active kind of case reflects risk. But we have to be really careful about that. And these theories really just set up a framework for that ideation to action framework. Framework.
Which is important because there's how do we get from ideators to attempters, right? Like where does it go? Where is that shift? And so this the evidence synthesis program at the VA Portland, Dr. Haney, Dr. Maya O'Neill et al. In 2012, they utilized this model to explore individual risk factors, clinically relevant risk factors, and to predict suicide outcomes, and explored this multi-level model of understanding context around what is driving risk. Two things to mention, because I know we're short on time. The scale for suicidal ideation and the Beck hopelessness scale were two of the only very few measures that actually demonstrated association with death by suicide. So that was the scale for suicidal ideation and this Beck hopelessness scale. We'll talk about that in just a minute. And the study suggested that significant predictors of suicide attempts included prior suicide attempt and depressive symptoms as measured with the Beck Depression Inventory, the BDI. Suicidality over psychiatric having comorbid psychiatric symptoms, and then alcohol and cocaine abuse were predictors of suicide attempts. So remember, again, as we are noticing, kind of holding that in mind when we do our risk formulation, and remembering that these are predictors of suicide, even though our data is not great. So this is the biopsychosocial model of suicide risk. And since suicide is so complex a topic, we need to take a more comprehensive approach to understanding its complexities. For instance, some socioeconomic risk factors for suicide may operate differently depending on the social context. So we know suicide risk is 3 times higher for gender and sexual minorities, and risk of suicide amongst individuals from minority ethnic groups is higher, especially when they live in areas amongst individuals that don't have a lot of, in areas that don't have a lot of other individuals that are similar to them, that a similar minority group or similar sexual minority group. And so when they live in areas that have a low proportion of similar like people, the suicide risk actually increases. And we saw that here in Oregon and across the country. When I was working at the VA, we did a telepride program where we did a virtual program that was a health education program that we helped LGBTQ plus individuals and veterans advocate for themselves in this healthcare settings to help decrease risk and improve access to meats in one of these underserved populations. So, and the veterans found it really helpful to build a community where they got to connect and explore their identities and felt safe among peers, and we saw decreases in depressive symptoms and suicidality in that group as well by having that support system. So some factors that might immediately precipitate suicidal behavior, you want to look out for those like job loss, relationship breakdown, social isolation that's resulting from anxiety. So people are isolating because they're anxious. Bereavement is a big one. So when we would have participants in our randomized controlled trials in New York, where we do the R01, R03 RCTs. When participants would say that they want to kill themselves, but they wouldn't because they want to see their loved one in the afterlife again, that's actually a really protective factor. Right? We saw that as something that's like really protective against them acting on those thoughts. So, as Dr. I was saying, clusters of suicide deaths can occur in young people through social cognition or social contagion, and those can account for 1 to 2% of suicide in children and young people. So we really have to look out for those. And so it's really important to understand how early adverse childhood experiences, right? We talk about the ACEs scale. It's 10 questions. If you have a score of 4 or more, or you've had a lot of adverse childhood experiences, and that can lead to physiological stress reactivity, and it can lead to increased vulnerability to stress. And you can pass that down epigenetically, the sensitivity. And then combined with these contextual factors, it contributes to this clinical picture of risk. And you need to hold all these factors in mind to understand the individual and context. So that I finished that. I think we are ready for our break. If we can take a quick break and come back at 10 o'clock, we will see you all at 10.
Okay, Julie, let's see if we can get those marks away. I was doing some Googling, and I think if you just do Command Z undo, it'll undo the last things you've done on the PowerPoint, which will hopefully erase those lines.
It's not look like that is.
Yeah.
Is it working in the Google? Hmm. Did it work? No.
No, you just, the color matches your background color. Okay.
Is it in the PowerPoint or is it on this in the Zoom?
I'll be right
Um,
back.
Okay.
I think it's on the Zoom.
On the Zoom.
Okay.
I tried to look for, someone said to go to the bottom of the screen, but I didn't see. Oh, annotate. I see it up at the
There you
top.
go.
Yeah, is there that annotate?
And
I
erase.
thought you had done it on the PowerPoint, but there we
Oh,
go.
there you got it.
Perfect.
Oh, yes. Okay. And did I X that out? Oh, perfect.
Okay, awesome. Now you can take your break. Thank you.
I'll be right back. Thanks.
Are we ready to start, or we have to have another minute?
Think that we can start. So now we are shifting to the tools and the risk assessment. So our poll question we have is I'd like to start with the poll question as everyone comes back. We want to know what evidence-based tools you currently use to screen and assess for suicidality in your current practice. If you could type in the chat what assessments or screens you use now currently, so we could get an idea of what people are already using. So yes, SRS, the Columbia, CAMS, Columbia system with aspects of CAMS, Columbia CAMS, CAMS for long-term cases. Oh, the Linehan. The ASQ or ASK. Okay, great. Well, thank you all for sharing. We're going to move on to the next slide. This is as one participant pointed out, these are kind of heavy slides, text heavy slides. That's why we wanted to give you the PDF in advance so you could zoom in and look at them while we're talking about these topics. This is an overview of the recommendations that we're going to talk about today to augment clinical interview with validated screens and assessment tools that we have based on the research to date. And this model supports more multimodal assessment and interventions. And there's a recent study, interestingly, so the implicit association tests, where they figured out a way to assess our unconscious bias. They were looking at whether you identified with death identification or life identification using the implicit associations test. So they're looking at trying to assess suicide risk using a more objective measure, the IAT. And they found that identifying with death identity on the IAT predicted future self-directed violence after leaving the inpatient unit. So we have some promising objective measures. There's a push towards using electronic health records or large systems to try to identify or screen identified patients that might be at risk for suicide. To date, we don't really have anything that's working, but there's two tools that we have. There's a stratification tool for opioid risk management. It's called STORM that the VA is using to try to determine if they can identify from the electronic health record people who might be at risk for overdose for opioid prescriptions. And they customize risk mitigation strategies for patients with active opioid prescriptions. And so common risk mitigation strategies, which we'll get into later, but just some examples, are offering medications for the OUD, or offering overdose education and naloxone distribution, and then developing a suicide safety plan. So we'll talk more about that, but this is just kind of an overview of some suicide prevention strategies. So these are all the, oh, did I skip? Okay, so these are the screening assessments. I think something happened with the formatting on this one. There's a bunch of them. So if you click on this link right here, it takes you to the Mental Health Commission of Canada, and they created a suicide assessment toolkit, which has a table comparing all the screens and assessments for suicide risk across a lot of these helpful categories that we're looking at, like time it takes to administer, population, administration variables. So check out that website that has all of those assessments on there. And this is a list of the screens, suicide screening assessment. So I didn't see anyone put the PHQ-9 in there, but some people use the PHQ-9, question number 9, as their main suicide screen. It looked like the Columbia Suicide Severity Rating Scale was the screen that most people were using in their practice. The Beck, down at the bottom, the Beck Suicide Intent Scale, or the Beck Scale for Suicidal Ideation, that might be used for more chronic populations. The Valued Living Questionnaire is more acceptance and commitment therapy focused. So Dr. Steve Hayes is my mentor, and he trained me on using the Valued Living Questionnaire and the AAQ2 and other acceptance strategies. And these are just some, we'll talk a little bit more about how you'll choose the different assessments. These are just some examples of some assessments. So I think having my mouse is stuck, or hold on a second, I'm having some technical difficulties. Okay. So, so as you can see, there's lots of screens and assessments. So there's no gold standard tool to predict attempts or if non-fatal injury reliably. And so the clinical practice guidelines recommend a multimodal assessment. So we're using screening tools like the Columbia, using a clinical interview and augmenting that with a comprehensive suicide risk evaluation or assessment. And as you can see, there's lots of different ones that we could use. But when we choose a tool, we want to think, how will it inform my risk assessments? And what you can do is you can start measuring baseline and then movement over time. So that helps us assess that, like kind of keep track of that dynamic nature, the suicidality, that risk profile can shift depending on the context. So for example, the Beck scale for suicidal ideation, the BSS, you can use that as a baseline risk level assessment, right? And then refer back to that throughout your work with that client. The 2012 evidence synthesis project that I mentioned earlier, it suggested the Beck scale for suicidal ideation and the Beck hopelessness scale is those two measures that have that known association with death by suicide. They also found that the Beck depression inventory and the personality assessment inventory, the PAI, were also potential predictors, but PAI is pretty intensive, and that would be a really long one to do for suicidality, as the personality assessment. The ASQ or ASK was also looking promising for predictive for veteran population, and they tend to give that ASK in emergency room department as screeners. And then if someone is not declines to do the CFUN, they'll give the this brief suicide safety assessment here, this third one. So I wanted to just point out the caveat that the suicide assessment interview, I just wanted to add that for practitioners in independent practice, David Burns has an interview that goes through all of these risk factors, and it's pretty easy to follow. However, the SAFE-T is the one that is generally used in healthcare settings for suicide risk evaluation. And then the comprehensive suicide risk evaluation is a little bit longer. I put a link here, and it goes through the risk and protective factors and mediation or the mitigation plans or strategies. And the VA uses that. So the VA starts with the Columbia suicide screen, and then if you screen positive, they move on to the comprehensive suicide risk and evaluation, where you assign risk levels. So I was gonna show us the CAM suicide status form, but I'm having computer difficulties. So I don't think I could show that, but I have a link there so you can check it out. That could be, these could be helpful for you if you have an independent practice. If you have more chronic patients, the Linehan and Risk Assessment and Management Protocol, and also the University of Washington protocol, those two, if you go to that website, it has those measures on there that you can print out and use, which was really great. A really great resource to have. So David Job says that if you use the SSF form, the suicide status form, that it goes over all the warning signs, the theories, like how much hopelessness, how much psychological pain. And it also has like the risk factors and the drivers for suicide, reasons for living, reasons for dying, all in one tool. So I was going to have us look at it, but for time, I will skip that. And so what you can do is you can sit next to the person side by side with your CAMS form and fill it out together. If you're virtual, you could do this and sit side by side with the clients and do that as well with them. If you like also facing them is also works. Job says that you can use that form, the SSF form, as your note or documentation too. So I heard recently that David Jobs has a new book out for CAMS. It actually walks you through the CAMS suicide assessment, this risk formulation process that we're talking about today. And I heard that's really good. So it's really helpful. That might be something that you'd want to check out if you were looking for an easy to use and easy to apply resource. In our references, there's a DBT diary for youths who are addicted to substances or opioids. So that could be one that you use as well. It includes like the full comprehensive all on one page. So we put some resources in that in the the book. Is it Managing Suicidality? It's the new David Jobs book. I forgot to look up that title, but I believe it's Managing Suicidality. And then, so I guess you've all used this already. So I was going to go through it more in depth. But since you all use it already, I probably won't go as in depth. I just want to give you an example. So the Lighthouse Project, they have a QR code that you can direct clients to this website. They take a picture of the QR code and they get the app or assessment on their phone. And they can take the Columbia on their phone and show you their results. So that might make the assessment easier for you or quicker for you. You can also walk through it. You could use it as a screener using the first 2 questions. And then, of course, that last question. You go through, and if there's a positive yes to items 3, where it's asking about method, or 4, where it's asking about intention, or 5, where it's asking about plan, or prep behaviors in the last 3 months, that's all a positive screen. And this scale offers a level of specificity that can be helpful in identifying people who are at risk for suicide. And so you could ask anywhere from three questions minimum, and they could screen negative, right? And they're not at risk. We're not identifying them as risk for suicide. Or you can ask up to the 8 questions, and you'll just keep moving through all the questions until if a yes is answered to that previous item. So a positive screening indicates that the client has thought of a way to kill themselves within the last month, and or has engaged in preparatory behaviors in the last 3 months, and further evaluation is needed. And we'll talk more about that later.
I think we're back. Go back 1 slide. Do you mind? Or thank you. Briefly, regarding selecting an evidence-based screen or assessment tool, and perhaps it should have just sort of differentiated this, but screens, as you may or may not know, are the briefer questions that we are asking that are pretty explicit about suicide. And then the assessment piece is the deeper piece, is when somebody has maybe said yes to a screening question that we then follow up with the assessment. And I think that's important to differentiate, especially if you're working in a system, because not everyone across a system can do an assessment. That's a more specialized approach. But the screeners, a lot of people are involved in the screening process per se. I think a couple of key things here is to not discount the group that you're providing services to. For example, when I worked on the Navajo reservation, there's no word in the Navajo culture. There's no one word for suicide. And so it became problematic. I'm not Indigenous, and I would walk in and present, to ER staff, to dentists, like, we're going to be doing these screenings as part of the Zero Suicide Initiative. The buy-in was very challenging, and that's putting it mildly. So we had to tailor the language a little bit, and that's not following an evidence-based pathway per se. However, there's really no evidence with certain cultures and certain groups. There's really, they're working on it across the reservation, but it's not been normed for certain groups, right? And you can look up different things on this, but we do know, on a good note, we do know that, like, the ASQ that Dr. Julie mentioned, the ASQ was normed for pediatric initially, and it has a robust set of nursing scripts. So that helps guide frontline staff with follow-up questions or approaches. And so those kinds of packages, if you can get that in a system, it can be very powerful. It's just, there's another question, like, after the screening and assessment, then what? For example, how many times am I going to screen? Is it going to be each point of patient contact? Is it universal or selective? I mean, there's a lot of considerations here. The fidelity to the screening measures. I've got a lot of people that I used to train in healthcare systems that approached it as if it was a checklist. And we absolutely can't do that. And so what I do is I've trained primary care clinicians or frontline staff, mostly nursing, I sort of train them how to have a conversation about suicide. So to kind of try to get it in their minds, how they would ask somebody, or how they would want their family member asked if their family member presented and we had to screen. And that really helped because people sort of took the approach that they had to, like, rigidly follow this protocol. They don't always have to do that, because we're inviting and normalizing the conversation around suicide in a non-threatening, non-judgmental way. But at the end of the day, we are supposed to, it is recommended that we do ask explicitly about suicide. Those are some key things I wanted to highlight here, just to remember that the screening is not to predict, it's starting to plan. It's starting to create a pathway. So if the person says yes, then what do I do? And so you have to really, I think about that and bolster the competency and the confidence levels of your team members if you're working in a system. This slide was just to highlight, because I'm still on faculty with Zero Suicide, and Zero Suicide, there's a free listserv that you can join. There are free resources on their websites. Even if you don't work for a healthcare system, it still has some really great up-to-date evidence approaches, and it has a lot of just really amazing resources that they share, and they're free. But one of the key principles of the Zero Suicide approach is that it's a systems-wide approach, that everyone is trained in some capacity. So we had even people that were working in housekeeping at a hospital on the res. We had them at least take a mini gatekeeper training. So if they saw anybody that was having perhaps like a mental health challenge, or just crying, or a fight, or something that was apart from the behavioral health clinic, that they could at least alert somebody or have somebody loop somebody into the conversation. And another key piece that I wanted to just highlight is the diffusion of responsibility, so that it doesn't just fall on like the mental health professional or the psychologist, because I was that person in a big system on a reservation, and that was scary and not good, not safe. But we work slowly to change these things. And so, like, this conversation today is already, it's going to be helpful because we're talking about integrating our efforts. Next slide.
Okay, so I wanted to give you a little bit of an overview of what the updates to the clinical practice guidelines are. Just a little bit about I think, did I skip one? So when we talk about evidence-based practice, we're talking about this collaborative, active decision-making process about how we're providing care to our clients, and we're using, scientific evidence about our available instruments and treatments, and look at the evidence that's in support of them, and then combine with the patient preferences and our clinical resources. So patient preference is a large part of this, especially when we're making our mitigation and safety plans. And the clinical practice guidelines, or CPGs, I'll call them, they summarize the strength of the evidence for clinical interventions. They use systematic reviews and meta-analyses of the most highly controlled studies. So we're looking at these these guidelines that the VA DoD clinical practice guidelines are really key in establishing consistent delivery of evidence-based practices by selecting these evidence-based treatments that are recommended for first-line treatments by subject matter experts. So the CPG was for suicide assessment and prevention assessment and management was updated this April 2024. For this edition, they shifted. So they use this grade criteria, and they really wanted to address two elements. So they want to address risk of bias, which is how much noise, right? Try to get rid of that extra noise for really high confidence that the results of our study are because of our intervention, and that there's not a lot of extra risk of bias there. So we want low risk of bias. And so that primarily focuses on evidence from RCTs. So you want to study with a lower risk of bias. That means it's well done. Maybe it has a large sample and hopefully demonstrates effective interventions. And they decided to only look at studies that had a direct outcome for suicide. Interventions for suicide mortality or non-fatal suicide attempts were also considered. So they shifted, rather than having these other factors that they were looking at as outcome variables, they shifted to only looking at studies that had suicide mortality as the outcome variable. But there's a problem because of this dual emphasis on suicide death as the primary outcome of interest, and then using RCTs to evaluate the quality of existing evidence. It's leading to challenges to this traditional CPG process because there's some limitations. Suicide death is a low frequency event, even in active duty military populations. It doesn't happen very often. So RCTs will generally be underpowered for detecting what might be efficacious for reducing suicide death, but there just wouldn't be enough instances to study and to make statistical inferences from that can be generalizable to broader populations. So that's one measurement issue. And then to date, there's a dearth of high quality RCTs with suicide mortality as the primary outcome. We just don't have that data or research. So they made these changes to the recommendations, reflecting kind of more stringent grading criteria, in hopes the research will adjust and we'll have better predictive data in the future. But given the low event rate and small sample size and all the follow-up requirements of RCTs, using RCTs might be too prohibitive to get the data that we need. So they're looking at other solutions, like I've been talking about, large healthcare systems as potential solutions. ReachVet is that algorithm they've been testing at the VA. But interestingly, they have not found an association with reducing suicide mortality rates with the ReachVet algorithm. They aren't able to predict that yet, but they are noticing that by using that system, that is enhancing engagement with care providers and other protective factors that would reduce risk. And so this just is an overview of the changes that happened in April of this year For suicide prevention and assessment, we had clinical practice guidelines in 2019, so those were the previous ones. And if the CPGs were to start by identifying people at risk for suicide, that's step number one. And that's that evidence-based intervention. But the new CPG created an updated algorithm. It walks providers through this evidence-based process, algorithm A, B, and C. And I gave you all a handout that has the providers summary card that will go over that, and we'll go over that more thoroughly in just a few minutes. And so interestingly, there was insufficient evidence for safety planning and crisis response planning. And which I believe is crisis response planning that's in the CBT for suicide prevention as a strategy. I think that's lethal means where they add to that versus safety planning, but I'm not sure. I'd have to double check that. And so for DBT, they were finding insufficient evidence for or against for utilizing DBT for those with suicidality. And then another change is that they suggested multi-component community interventions. So that kind of goes along with those models of suicide prevention and those more biopsychosocial models where we're looking at this broader context. And then they suggested reducing access to means to reduce the risk of suicide by firearms, jumping, or medication overdose. But just because the clinical practice guidelines does not have data we don't have data that says that screens, risk assessments, or safety plans, we don't have sufficient evidence for that, but that doesn't mean don't do them, right? We want you to still do them because the best practices for the for CARF, the Commission on Accreditation of Rehabilitation Facilities, and the Joint Commission still say that the standard practice of care, best practice of care is identifying those at risk of suicide, and then engaging in suicide risk assessment screening, and then risk mitigation strategies and management. So those are the still the standards of care, even though we don't have the evidence for it. But as I was describing, there's reasons why we don't have the evidence for that and why it's changed and shifted. But it doesn't mean don't do it. We still want you to do that. So despite that shift, really the focus is on identifying and monitoring individuals at risk for suicide and really adopted as part of routine care proactively. So if you have a system and you're not assessing or screening individuals, you want to start assessing. That's per the CARF and the Joint Commission, you'd want to start assessing individuals and monitoring individuals at risk for suicide. And that leads to further assessment and implementation of individual risk mitigation strategies that you can also build into your system practices and processes. So the best practices from Joint Commission is screen all individuals for suicidal ideation. So anyone coming into contact with you in your healthcare setting, and doing it by using validated screening tools. Like we looked at those slides with the Columbia, PHQ-9, etc. And we really want to ask patients to, part of that assessment requirements as like the best practices from the Joint Commission and CARF is to ask patients to describe direct and indirect warning signs prior to the most recent exacerbation of suicidal ideation or suicidal behavior. Interestingly, there are some studies that were looking at suicidal ideation and depressive symptoms, and they found a unidirectional relationship between suicide and depressive symptoms. So suicide symptoms change the session before actually reduce depression symptoms the next session, but suicide symptom change did not correlate with the depressive symptoms the session prior. So they're noticing a unidirectional relationship, which might suggest that targeting suicide specifically would help to reduce those suicidal symptoms. Kind of like with sleep, sometimes we talk about with insomnia, if you treat the insomnia, it might help reduce the depression symptoms. So that also gives us a little bit more evidence that these studies we have that aren't directly linked with reducing mortality per se, And those recommendations change as well with this clinical practice guidelines, yet still CBT, right? That's the most consistent one that's been recommended. And CAMS and DBT are still part of these standards of practice at targeting suicide-specific interventions, even though we don't have the data for it. Oh, I have been on a different screen. So this is the updated algorithm, which outlines the evidence-based assessments and management of suicide clinical practice guidelines recommendations. As you see here, since most people who die by suicide see a healthcare provider within 12 months of death, like Dr. I had mentioned before, it's really important to screen for suicide risk, ideally using a validated tool, either when they come into contact with your healthcare system, each time that you meet with them, or when you're noticing a change from baseline. So we want to start collecting, catching all the people and at least screening them to see if we can identify. That's the main goal, identifying people who might be at risk for suicide. So someone expresses suicidal ideation, either directly or indirectly, or there's changes in baseline or changes in these acute dynamic stressors, then we want to make sure that we're screening and engaging in this process. So what is an evidence-based risk assessment? Right, we have the step one, we're screening with validated tools, and then identifying individuals at risk for suicide. So the warning signs like suicidal ideation, recent suicidal self-directed violence. If we're using those predictive models, we might identify high-risk patients or clients from there. Or when we're doing routine suicide screening, we might identify individuals from there. Then the next step, if there's a positive screen in step one in algorithm A, you're on to algorithm B with the comprehensive suicide risk assessment and stratification. And risk stratification, so that's the safety, the comprehensive suicide risk evaluation, and we'll practice that more in this next section. Risk stratification is this lens to view this comprehensive, dynamic, complex, varied, all of these different factors that you're holding, as well as establishing a standardized pathway that guides clinical decision making and intervention planning. So then, depending on the risk level, right, as with part B, when we get that risk level, the risk stratification, then we can go to algorithm C, the risk mitigation plans and follow-up management of patients that are acute risk for suicide. So if you have your CPG provider pocket summary out, we'll be walking through those steps. We're starting with algorithm A, this routine care for suicide prevention, identifying risk. And then you're going to directly target suicidal thoughts and behaviors by asking them directly, like Dr. I said. And I'll turn it over to Dr. I.
Thank you. I just wanted to, just as a reminder, I know I've said this, but just the reality is that there are a lot of people that have experienced thoughts of suicide, and we may encounter them in different ways, in different contexts, but inviting people to have a conversation, normalizing it, even modeling that for other people, I think is really important. Something that I struggled with was the lack of postvention, or the lack of policies and procedures that were, the lack of policy and procedures around what happens like in the workplace setting with suicidality. Like if clinicians aren't talking about it with each other, how are we expected to be present and ask about suicide with our patients or with the people that we serve? And so I think it's a balance act in a way, being person-centered, contextual, understanding that there's a narrative, there's a suicide narrative for folks or their own stories, and also utilizing like consistent practices, and building that core competency and confidence levels across staff members and teams. And remembering that like these tools are just tools. They're not at all robust enough. Like if you contrast something like the Columbia with the LRAMP or CAMS, I mean, there's a stark contrast there. And so I never tell everybody, I never tell anyone, you know, you should be using this tool and this is the one for you. That's for you to decide. It really has to be a fit, and it has to be something that you feel like is going to be effective and useful, something that's feasible. And I always want to like sort of drive that message home, because there's just like I've had people in trainings in the past that are, you know, equipped and like, oh, I'm used to asking this. They're like behavioral health professionals in public health places. And yet when we sit and do like a hands-on training, which I usually add on, much to people's dismay, like, I know you did that training online, but now we're going to do a check-in and like a little bit of, you know, practice. You'd be surprised, like people don't want to have to say the words out loud, even the word suicide. So I often have them imagine that one of their family members, someone that they love, is walking into the clinic, and how would they want that person approached? And that's been really helpful, a way to get people to imagine and personalize it a bit. That's really all I wanted to mention with this slide, but I appreciate all the comments and queries that we're getting while we're talking today. It's a heavy topic.
So we'll shift into risk stratification levels, and we'll be using these when we do our risk formulation. In the last section of today. So there's a model that the Veteran Affairs is using. Is called the TRM model, or the Therapeutic Risk Management Model. And I believe that's the link to it. And if not, I will share the link with that, the Therapeutic Risk Model of Risk with you later. It breaks risk into two factors. So we're looking at risk in terms of temporality, where we're looking at whether it's acute, right, within minutes to days, or chronic, right, more longer term. So that's one factor. And then also severity levels. So severity levels of high, intermediate, and low risk. And as part of the therapeutic risk management model, which they say on their website, they have great trainings there. Someone was asking about trainings. They have some great ones on there. That you want to assess for both acute and chronic lists, and provide it a severity designation of high, intermediate, or low risk for both of them. And it's part of the therapeutic risk management model. And that's above probably the standards of care, but also like that's what I do. That's what a lot of providers in the healthcare systems do. It's a really robust model that's really helpful for clients and for the clinician. It's really collaborative and therapeutic. Well, another different model that you could do, and when I talk about the note documentation, I think that it's part of the link there, or it's on the TRM website, that it's called risk benefit analysis. So essentially, right, rather than doing maybe a more formal risk assessment, you could just document your clinical decision making in the electronic health record. And I'll give you a link when we talk about documentation that gives you some examples of how you could do that. So when we look at the TRM, the therapeutic risk management model, which is like above the standard practices, it initially involved three components of augmenting clinical risk assessment with these structured instruments, and then stratifying risk with the severity and temporality, and then collaboratively developing a safety plan. But they've added more recently onto that model, and include things like a chain analysis, which is I'm going to give an example of, to really further explore the function of the client's suicidal thought so that we can have more targeted interventions. And then they've included lethal means safety guidance and recommendations, which I'll give you an example of my spiel I give to clients for lethal means safety. I provide that to all my clients, and I do risk assessments to all my clients. And then they suggest obtaining collateral data for support persons in the client's life so that you can take both the subjective report of the client and also these other collateral reports and combine that information to have maybe more robust risk assessment. And then using welfare checks as part of therapeutic risk management and post-vention planning services to really support suicide survivors. So as part of this, they stratify, as part of this TRM, this therapeutic risk management model, then they break it into high, intermediate, and low risk. So this is looking at just acute risk, this like immediate, are they safe, right, within the next few minutes, hours, days risk. And high risk is when you have suicidal intent. So I saw a question about, do we even need to assess for suicidal intent? Actually, yes, we definitely want to assess for suicidal intent. Not just because the TJC and the CARF right have suggested those are the best practices of asking for about suicidal ideation, plan, risk factors, and these risk mitigation strategies and documentation. Like that's the standard of care. So high risk is suicidal intent combined with inability to maintain safety independently of external support or help. So they might say they're not safe right now, and that if they leave your sites, something bad will happen to them or they might hurt themselves immediately. So you can't let them leave your sites. And we'll talk about the risk mitigation strategies about that later. But for intermediate, so the difference between high and intermediate is suicidal ideation is intermediate, right? We had intent with the high, and we have suicidal ideation for the intermediate with the ability to maintain safety. So we're seeing that the intermediate is the same as high risk, except for the lack of intent. And one way to determine risk levels to ask clients, so sometimes I ask them this because this is the hardest question, right? Is it intermediate? Is it high? Right? It's really unclear a lot of the times. So sometimes I'll ask people to help me try to make that distinction. So on a scale from 0 to 10, like I'm not quite sure, I've asked them a lot of questions. A scale from 0 to 10, how likely are you to act on these thoughts? 0, not at all. 10, very likely I'm going to kill myself right now. And then they'll give you a number and you can follow up like, why not closer to 10? Right? Like what would make you closer to 10 that you're going to actually act? And what would make you closer to 0? And if you're working with them maybe more longer term, like where is the cutoff or like danger zone? Like if we go above this number, and what are the signs in your body? And I'll give you another example of how I talk to clients about that later. But if we go above this number, like what would we need? And would you need to engage in your coping plan and list your support? You can kind of make those plans with them. That gives you a better idea of that acute, more level of risk and how to make that distinction between intermediate and high acute. And low is no current ideation intent plan, no prep behavior. For chronic risk, it's the same designation. So they have high, intermediate, and chronic, but this is looking for that longer term risk. It's holding those concerning historical risk factors of past suicidal directed violence that might increase risk. We want to hold those in mind while we're looking at severity. So chronic high risk is for individuals considered to be at chronic risk for becoming acutely suicidal. Often when we see these psychosocial stressors happen, so like job loss, relationship loss, like recurrence of drug relapse use. We might see risk factors of chronic psychiatric mental health conditions, chronic pain. So we've seen these comorbidities that increases risk. Suicidal ideation history, is it chronic? How intense? Have they acted on it in the past? Is there a history of prior suicide attempts? So that's the one thing definitely, right? For this high chronic risk, is there a history for suicide, or is there a history of a suicide attempt? That might indicate they've actually acted on it before, right? So we might indicate a high chronic risk. And history of substance use disorder, limited ability to identify reasons for living. Can't really say reasons for living or protective factors. That's a big warning sign right there. and limited coping skills, right? Not able to identify any coping skills that they might utilize to reduce the risk or to reduce the emotional distress. And if there's any unstable psychosocial housing or status changes, or even just unstable status, right? Like the unstable housing, erratic relationships, underemployed or more marginally employed. And intermediate chronic similar, but we see more balanced protective factors. We see those coping skills, reasons for living are there. There's some relative psychosocial ability. So like most areas of their lives or domains, they're able to at least function like going to work or in other areas. And they and this stability protects from elevations in risk. And it helps us kind of like have a little bit more confidence that even when there is elevated risk and we're designating them at the intermediate chronic risk level, that if there are changes in psychosocial stressors, we want to address that and keep an eye out for it, but that they'll be able to maintain that safety independently, ability to endure, kind of indicates an ability to endure future crises without engaging in suicidal self-directed violence, because they haven't done that in the past. And so low chronic risk is ranging from those with little to no mental health problems, stressors, stressors have been endured without suicidal ideation emerging. So we're really looking at that history of suicidal ideation, as Dr. I had mentioned before, right? In chronic risk, and we see this like more chronic clients, which is a whole different presentation. Chronic versus acute suicidality is a completely different intervention, right? Someone was talking about that ambivalence. And oh my gosh, we'll talk more about it later because I know we're close to going on break right now. But like with that ambivalence, like if you've had these really difficult life experiences in childhood where you weren't validated, and it's hard to make sense of yourself in the world, and amongst others, right? And there's like a lot of tumults and right this dysregulation in emotions, and like of course you're gonna have ambivalence, right? Your nervous system like learned like kind of ambivalence was protective as a childhood in that powerless situation with all those adverse events, right? And so it's actually pretty protective to be like, oh, I don't know if I'm about this living or dying, right? Like it was a way to protect them in childhood. But we see that can persisting into adulthood with some of these more chronic presentations of chronic suicidality. And we really need to address that with life worth living goals. Really, really address that ambivalence, because right, that keeps them stuck in that dysregulated state and away from the present moment, right? And that makes it more dysregulated, more likely to be affected by those psychosocial stressors. And then I had something else I was going to say about that, but it has slipped my mind and I'm noticing the time, and we wanted to give you a break. So if you could all take a break, and we'll see you back at 11 o'clock. Is that okay, Dr. I? Is that what you were thinking?
I think so. Yeah, let's do that. And then when we come back, I wanted to talk about what Laura mentioned in the chat and about the limitations of risk levels. So we're going to come back at, did we say I'm on a different time zone? What time did we say?
11?
11 o'clock? Okay, thank you.
Okay, we'll see you then. Okay, so I think it's 11 o'clock and we're gonna jump back in so that we can keep on track today. So thank you for bearing with us. That was a lot of information, heavy, those first two sections. Were you gonna say something, Dr. I?
No, just that it's just such a heavy topic. It's because it's like we're professionally impacted, but a lot of us are personally impacted, and I have a real sensitivity to this, in the sense of, just what clinicians go through, because I've worked with a lot of them that have lost patients to suicide, or worked in systems of care where they lost a colleague, and it's just a really challenging topic. So are we on the next slide, Dr. Julie, or are we? Yeah.
Yes.
Yeah, so and there's been some posts in the chat. There are some real limitations to these risk levels. They're reductive in a way. They don't account for the fluid factors often. They are limited. They don't sort of include that conceptualization of the narrative. There's a lack of a clear definition around what is the stability of a patient's mood or their psychosocial situation. I mean, it's relative. We have to consider our own biases and perceptions that we do tend to, the folks that are more explicitly verbally acknowledging suicidality, that they tend to get more focus, and we tend to conceptualize risk along those situations, or the factors in which they're more evident. And that's not as helpful, because a lot of the time there are folks that, I mean, the quiet ones are the ones that worry me, and the ones that are avoiding or evading engaging in any kind of assessment or conversation or treatment for that matter, those elevate the risks. And those are the folks I'm very concerned about. And I have one tip on that, but I wanted to also say that suicidal ideation is not constant. So even the best monitored patients, the ones that maybe I'm seeing at the VA like weekly, I'm assessing their thoughts, perhaps just, with a self-report tool, right? It's really not enough. What's recommended now is that clinicians should try to look for more patterns versus one distinct moment in time. And these single points in time, they aren't robust enough. And that there are rapid, sometimes not rapid, but there can be accelerations in the ups and downs in ideation. It's sort of that emotional roller coaster, or folks that won't tell you when things are happening, and those are problematic, and that limits what we can do sometimes. However, the tip, or the anecdote I can share with you, and now it's actually a recommendation, is that we continue to sort of, I guess, dog with a bone, that we're relentless in our pursuit of really helping folks that are experiencing suicidality. And the tip that I have for you is, when I've worked in systems in which there are diverse or highly impacted or vulnerable groups or populations, I try to work with peers or persons with lived experience. We know that those are recommendations now, but like on the reservation, that was integral, because I had a Navajo, I had a behavioral health tech, and he was Navajo, and I think he had a family member that had died by suicide, and he worked in the ER, and he literally translated language wise, but also just the spirit of like, why is this person asking this? Why are these clinicians asking this? And another interesting thing that we did on the reservation was, and this could be more broadly utilized, was when we started screening in the pediatric department, we used a parent. So we used a Navajo woman that had some experience with suicide, but she was a not certified because we didn't have the certifications there, but she was a person with lived experience. And often she would place herself in the waiting area of the lobby. And when kids were getting screened, she kind of brought it up. She'd say, yeah, I didn't want my kids screened. And they usually go alone in a room with the nurse and they get those questions, especially the teens. She's like, I didn't want my kid to get asked those questions because people there felt like we were going to get them in trouble or something. And she said, but it was good we asked because they get help that way. And her saying that's something so simple was this like really amazing bridge to get some engagement and to normalize that conversation and to introduce that. So I think the systems-wide efforts to align the best practices, but also what's going to work with that community, that those are really excellent ways to go about it. And you have to be creative sometimes. We can go to the next slide. I hope that answered some of the questions that came in the chat. Oh, sorry.
Okay.
That's you. Sorry.
So this is algorithm B on your provider summary. So algorithm B is the comprehensive suicide risk assessment and stratification. So this is the actual assessment versus the screen. So you might use the comprehensive suicide risk, you might use the SSF, you might use, there's even a Columbia that has all of the protective factors on a sheet. I think I put that in the references as well. The goals of, so the Joint Commission requires that suicide risk assessment and stratification be a component of routine care for patients identified at risk. So this risk assessment and risk stratification is a routine care component. So I know someone was asking about that. And so when we're looking at suicide assessment, the goal is for when someone has suicidal thoughts or expresses suicidal behavior, we want to evaluate the factors that increase or decrease the risk of acting on that intent. And you want to integrate cohesive risk, level of risk severity, level of appropriateness of care, all of these factors into your assessment. And when you assess ideation, you want to ask directly, are you having thoughts of killing yourself? What are the thoughts? Can you tell me specifically, like what thoughts come up? What's going through your mind? Are there images? And then assess the contextual factors triggering or preceding the suicidal ideation or behavior. One of my supervisors when I was in grad school taught us the ORCID assessment. So the onset, so it's ORCID's the acronym, right? Like the mnemonic, the onset, response, course, history, intensity, duration, right? You want to get as much detail as possible. There's been a few recent studies that's using ecological momentary assessment data, or they're doing that, wearing wearables, tracking people around. Unsurprisingly, one of the studies was tracking people around on their phone, and people who were just staying in their house had more ideation versus when they were going out and about. They had less, oh, behavioral activation sounds familiar. Right, when you tell your clients, like even just going out of your house to anticipate someone is going to change your mood from down, right, to at least neutral, right? So we want to kind of get out of your house, self-regulate, co-regulate. What they found is they asked throughout the day about people's thoughts, and those who were in the category of very frequent, very intense, very often suicidal ideation, those were the high risk group. So we really want to see how often people are engaging with the suicidal ideation and thoughts. Are they like rehearsing in their mind? Are there family members who've died by suicide? Are they engaging in non-suicidal self-injury, right? Kind of this like exposure to these more serious behaviors that we want to look out for. Oh, someone put a mnemonic. I have that on my next slide. Before we go to the mnemonics, I kind of wanted to just give you a broad, like a kind of a brief assessment example. So kind of let you see the picture. So especially if it's a more chronic client, because I know people were asking about chronic. We were talking about the adverse childhood experiences and taking this trauma-informed lens approach to care, where, oh my goodness, if you had so many adverse experiences in childhood, right? We really can't take personally, right, when these clients are presenting in the way they are with distress or are angry, right? Like a big important part of this is holding that space, especially with these more chronic, agitated, dysregulated clients that are presenting, like not taking it personally, holding that space, regulating yourself, right? Like noticing where they're at, maybe even leaning back to, model for them, like breathe deeply, right? To come back into the assessment. And so it kind of using that Linehan protocol on the University of Washington website, this longer risk assessment, kind of walking through that briefly. You want to look at this narrative approach that we're talking about. You might want to ask them, if they're more chronic, you might want to start with what the initial onset of suicidal ideation history was, at what age, and in what context. So when did the suicidal ideation come about? And how did it function? It functioned in X way. So that's going to be the main overview that you want to be looking for in this brief example I'm going to give you, right? Initial onset of suicidal ideation history was at age X in X context, and it functioned in X way. So I might tell my clients, now I'm going to ask you some questions that I ask everyone. How old were you when you first had thoughts of suicide? Right? And a client might tell you that their initial age of onset was 7 years old. Then you ask more questions. Maybe it's around the context is family distress, so it occurs within family distress. And you see that the suicide function was escaping that family stress. So that's that kind of more narrative contextual approach. So you might ask them their history of prep behaviors and warning signs. Have you ever engaged in any preparatory behaviors where you went to a roof and didn't jump, or you wrote a letter, where you're gathering pills, where you collected a rope? What about your plan? Do you have a method, but not a specific plan? Have you gone and rehearsed engaging in that plan? What is the history of suicide attempts? What about failed or thwarted attempts? What type of lethality? So that will look at like the severity and risk for future scenarios. How or why was it stopped? Did someone else stop it? Did they stop it themselves? What was the client's response to the thwarted attempt? Were they upset? Are they more likely to do that again? And then non-suicidal self-injury, or the history and current and urges, right? So we also want to assess urges. We want to talk about substance use and some of these unhealthy behaviors, these more impulsive behaviors like non-suicidal self-injury. And really assessing the severity of past self-harm. Like, did you cut yourself so deeply you had to go to the hospital because you're so dysregulated, right? That might indicate that impulsivity, and then, right, acting and engaging in a more lethal outcome than was initially, like initially what was happening. Substance use, right? Is there substance use that's inhibiting, disinhibiting them, and they're more impulsive, they're more likely to act. One element that we haven't really touched on that much, but it's important to specify, are these more passive? Like, just wish, like, just to be easier if I wasn't here, right? Are these more morbid cognitions, more passive, right? So you might write morbid cognitions versus passive, right? Because that's a little bit more specific, versus active ideation. And you want to write quotes out. So what are your quotes? What exactly are you thinking? What are the exact thoughts that are coming up? And when are they coming up? What's their frequency, severity, intensity, duration? When is it happening? Every morning when you wake up, before you go to bed? What are the precursors, like what's happening right before? What are the consequences? Do you get attention from others when you engage in this behavior? And then how do they cope with thoughts? Is it maladaptive coping and adaptive coping mechanisms? And then let's find healthier coping tools. And then if there's time, then safety planning. So if someone talks about suicide, but then they're switching the subject, right? Really stop and take it seriously. Whoa, hold on. Whoa, let's come back to that. Like, this is serious, right? And then go back and assess that risk and express concern and really focus on that for the rest of the time, right? Until the risk level mitigation plan are completed and you know what the risk level is and what the plan is. And so someone put Douglas Marlowe. Oh, hello. Thank you for putting that mnemonic in. So I have some mnemonics up here that it might be helpful for trainees to think about this assessment. Is path warm? So looking at the ideation, substance use, purposelessness, anxiety or agitation, feeling trapped or hopeless, withdrawal, anger, recklessness, mood changes. And then I also included the modified SAD persona scale. It's based on the SADS person scale, which in literature has low sensitivity, but it has really high specificity. So it really helps us assess that risk. And I'm not sure why it's got cut off from the screen. Oh, maybe I didn't. Maybe it just got cut off on the screen. But it gives you risk level determinations. So we had talked about the SAFE-T. That's a tool. So this is also another comprehensive risk evaluation tool that they tend to use in more healthcare settings in primary care. And so this is for the B algorithm, right? The risk assessment and stratification using this simple 5-step process. It goes through identifying the risk factors, identifying protective factors, chronic conduct, suicide inquiry, determine risk level or intervention, and then document. And on the back, it has a list of protective factors and warning signs you can assess for. So you can kind of print this out for your staff and have it around as a handy pocket card for them. And now we're in algorithm C, management of patients at risk for suicide. We had talked about the therapeutic risk management model had those 3 original components of assessment, and they added the chain analysis for suicidal thoughts. So this picture demonstrates a chain analysis in dialectical behavioral therapy. You conduct a behavior chain analysis on a behavior that you want to change and create a new chain. Right? And we can't help but these chains come up, right? These are like learned automatic responses. They're part of that, right? Those neural pathways we've been developing as adults, they come up. Can't help but have them come up. And so we look at these behavioral principles, what's reinforcing, what is punishing, what are the consequences, and how is that impacting the behavior? And can we change these contingencies to address or target the suicidal behavior? And so we really want to slow down that 0 to 60 process of emotional distress. Right? We want to look at the environmental context, the vulnerabilities. So, right, these are your like sleep skills for DBT. If you haven't slept or you haven't taken your medication, you're definitely going to be more emotionally dysregulated. Often I have clients say like, oh my goodness, I didn't realize, right, with the tracking of the DBT diary card, how important sleep is, how I need that to regulate my emotions. Oh my goodness, that's why I was dysregulated last week. I forgot my medicine. I forgot to take my medication every day, right? And we use the diary and the chain analysis to make this new chain. And use skills, right? The police skill to reduce vulnerabilities. Look at the prompting event and the contingency surrounding the suicidal behavior. There's this term called differential reinforcing operant, right? If we're looking at substance use and we're trying to reduce maybe more impulsive acts and reduce substance use or access to substance use during times of high risk, we might ask like, well, what's a different thing you can do that you can't drink? Right, this differentially reinforcing like driving. Well, ideally we wouldn't do both, right? Like something where you're using your hands but you're not drinking, right? Other behavioral techniques to try to reduce that access or to stop them from going to the store. Like reasons why they don't want to drink at the door before they leave the house, so they don't go out and buy more. And then the drivers of risk. So are there certain symptoms that are driving risk? Are there the consequences that's driving risk? And we want to organize this suicidal ideation um, and behavior based on the functions it's serving for the individual. So we want to do a functional analysis. How is this behavior functioning? What are the consequences? Like, what is the function or need that this behavior is serving, rather than just looking at the symptom topography? We want to like really see what's underlying it. Like, why is this still coming around? Why is this maladaptive automatic response kind of coming up? Why is it still working? Why do you think that this is still successful at working, right? Even that like intermittent reinforcement skill, which is the hardest one to change, right? The slot machines, right? Oh, every 15 times, it's like you push the button and you get that reward, that reinforcement, right? And that's the hardest to break, right? And so then even something gets reinforced once out of 15, right? Oh, that's a hard reinforcement schedule. So that's why we want to use these behavior change and change the contingencies. And so what we might do is, right, it's not your fault what happened to you as a child, but as an adult, you're responsible to fix it. And so noticing these physical cues or sensations, because when we're in that high distress, and I'll talk about that in my spiel later when we talk about lethal means reduction counseling, we want them to be accountable for coping actively to address these, to not get dysregulated, to not get stuck in those unhelpful maladaptive chains, and really make a new chain. When this happens, right, when I feel this physical cue, then I'm going to try 10 things, 10, 20 things, keep trying things, and we'll make a plan for all the things to try. But active coping until the stress diminishes, or it's getting to that point where like, well, we have to decide maybe you have to go to the hospital, right? We're trying to reduce unnecessary hospitalizations. So these are the clinical practice guidelines. Oh, sorry, I'm noticing the messages. So ORCID is onset, response, course, history, intensity, and duration. Onset, response, course, history, intensity, how intense, and has that shifted across time? It's dependent on psychosocial stressors, and duration. So are they stuck all day in the suicidal ideation? Is it frequent, intense? Is it happening all the time? Is it more intrusive and unbidden? And those types of questions, and when it's showing up, will help us understand it a little bit better. So I'm going to shift to this because we're getting close to our practice. This is just an update on the evidence-based psychotherapies that this clinical practice guideline has made some changes to the recommendations. So CBT has the most research with recent reviews with evidence that really targeting suicidal thoughts and behaviors in high-risk adults really reduces self-harm at 6 months follow-up. They found similar responses with brief CBT, so about 12 sessions, at reducing the odds of suicide. So CBT has been the one that's the most constant. So CBT for suicide prevention goes through these assessments, creates a crisis plan, lethal means counseling, creates a coping box or survival toolkit. There's an app called Virtual Hope Box that I have my clients download. They can use distraction, calming, relaxation, inspirational quotes, right? That's their little like survival kit. Or I might have them make a box where they put in like weighted teddy bears, weighted blankets, coloring books, things to like help them cope during these times. And then so CBT's been the one that's most consistent and still recommended. DBT is a dialectical behavioral therapy. It combines acceptance versus change strategies that we see in the cognitive, but we're doing these more mindful acceptance strategies in DBT. And DBT has evidence that it reduces suicidal ideation and suicide attempts, but recent reviews or analyses suggest that DBT reduced the frequency of self-harm, but it didn't reduce the number of clients who repeated the self-harm during follow-up. So we weren't seeing that consistent result at that. And CAMS is collaborative assessment and management of suicidality that David Jobs created. In colleges, this is an inpatient units. This is an intervention that's kind of part of a stepped care intervention at times, or a frontline treatment. Depends on what your population. With college students, we were often doing it with a lot of college students sitting side by side for 2 to 4 sessions. Maybe an inpatient unit or a DT program, it might be 5 to 15 sessions, right, depending on the number of sessions. We really want to target those suicidal drivers, right? And the reasons for living versus reasons for dying in CAMS. And it's been shown to reduce suicidal ideation at 3 months, but not yet established whether it's effective at reducing suicide attempts. And then for older adults, problem-solving therapy was associated with reductions in suicidal ideation at 12 and 36 weeks compared to supportive therapy. And there's not a lot of evidence for older adult intervention. So I wanted to mention that problem-solving therapy, we're walking through these problem solving, taking that problem step by step, creating alternatives, creating maybe the best outcome or plan to try or to address the issue. Right, that gradual breaking down tasks, right, into smaller parts so that it's less overwhelming. And interpersonal psychotherapy has also been adapted for older adults and found to reduce suicidal ideation post-treatment. I really like that one. We kind of put patients in the recovery role, like the sick role, right? Like when you're on an airplane, right? When the masks fall down and you have a child, you need to put your mask on first, right? So we want you to take that recovery or sick role. Like, we're not going to engage in any of that suicidal ideation or behaviors while we're doing this treatment, so that we can really focus on getting better and healing and really addressing what's going on, so that we can make those changes and start to feel better. Oh, it didn't show up. You were right.
Yeah, it showed up on one version and then it wasn't on the other, but I guess we'll just imagine that there's a picture.
I have put a link to the safety plan, the Brown safety plan. It's in the references under resources.
Okay. So imagine if you've seen the Columbia, the collaborative safety plan. There's so many acronyms in my head right now. Imagine that you're seeing this plan. I'm trying to think, is there like a different, hold on, I just dropped my papers. I have some attentional deficit issues myself. You can leave it on the next slide because I'm staring at the blank and it's distracting. Okay. So the collaborative safety plan, can you just write in the chat if you've never used it before? Or if you've used it, the Stanley Brown safety plan, or if you use it at all? Never used it? Okay, cool. The Stanley Brown safety plan is a collaborative safety plan that it can be a standalone intervention. It has, if you saw the picture, or you can go to the link, it has, you use it in a stepwise manner. The components, the first one is like what preceded the actual suicidal crisis. So you work with someone to try to, map that out for them. So you are also teaching them, or they're learning. There's a learning principle involved as well, but they're defining or delineating internal strategies, things they can do by themselves to help themselves cope, and then external, you're listing professional resources. The cool thing about the Stanley Brown, the collaborative safety plan, is that you can use it iteratively, which I've done a lot. You may have gotten that vibe from me, because it has to be tailored for the patient. It can't just be like a fill-in. It's not another checklist. I trained people to do it at a clinic, in the ER, and I was noticing some people, were like, this takes so long, and they were spending like 30 minutes or 40 minutes, and other people were spending 5 minutes. So I was like, what's going on here? So we did a little bit of a qualitative assessment, and we figured out that, it's something you really need to sit and do with a patient. It's a standalone intervention. It is used as, an intervention a lot of times. evidence tells us, or research tells us, that people that sit and complete a safety plan, or patients rather, that complete a safety plan are more likely to attend their next follow-up session. And that's really exciting, because I think nationally, the last number I had was around 60%, or it might have been higher, closer to 70, did not attend the safety, I call it a safety check, but it was really the follow-up appointment after someone was evaluated, like in an ER for secondary to suicide. That people just didn't go to those appointments, and then we're calling them and we're trying to figure out how, are they safe? But that a safety plan can actually be really can really bolster the engagement. There's some research. There was a study done with veterans in which they used a safety plan. It's called like an SPI plus. If you're interested in it, I can try to find the link. But it was where a collaborative safety plan was done with veterans that were seen in the ER, secondary to suicidality. And this subset of patients never required hospitalization. But what they did in that study was they added on this structured follow-up phone call. And so you had to be someone that was trained, but there was a follow-up phone call that was placed, and it was not about any kind of risk or sorry, it wasn't about the hospitalization. It was focused on a check-in with the patient, with the veteran, focusing on more current acute issues, if anything that they noted on the safety plan that wasn't safe, or that was a particular stressor. They would check in about that. So it was a bit individually tailored. And then that study paid attention to the critical components of the narrative that corresponded to something called the suicidal risk curve, which we'll get into later. It's basically just the takeaway is any steps that increase the time and distance between a suicidal impulse and a firearm will reduce risk. And I'm just going to say that again, because on the collaborative safety plan, one of the last questions says, what's my what's the reason for living? The question right before that says, how do I keep my environment safe? And often it's about lethal means, right? But I've also worked with teenagers, maybe that there was a person that was stressing them out, or they were arguing with. And so interestingly, I'd say, how do we keep you safe? How do we keep your environment, your place safe? And they'd say, well, I think I need to stay away from him or her, or they, but I think I need to stay away from those arguments, or I need to like spend some time alone or something. But they had something to say there, because I was always like, what? There can't just be one thing that I'm living for, or one way to keep people safe, but you can use it to expand it. So I'll repeat the thing that I said, which is the most important, which any steps that increase the time and distance between a suicidal, we'll call it an impulse or an urge, and a firearm will reduce the risk. And if you want a great resource, the Public School of Health at Harvard did this whole, it's fantastic, this whole project on means matters. And so if you just look up like Harvard, I forgot what the name of their public health school is, but it's means matter. And there's a lot of really cool stuff in there. But the safety, just to wrap up, the collaborative safety plan is, it's a conversation. It's something that can be formally documented. You can, like when I worked in the ER doing assessments, I would give the patient a copy. I'd ask them to come back for a follow-up appointment. And someone asked in the chat, so nationally, and this is a few years ago, nationally, about 60% do not make it to that follow-up appointment. Typically, it's with an outpatient provider. They don't make it. When I worked on the reservation, our small N that we had was about 70%. After implementing the collaborative suicide plan in the ER, I literally had about, I would say, an increase in folks that would attend that appointment. And literally, what I was shocked, they would like come in with their suicide plan, like their copy. And, that just warms all of our hearts that do clinical work, because I was like, oh, wow, we did that. And so just had a lot, there was a lot of meaning for that. Someone's asking about the statistics. So I'll look that up for you, Jenna, and share it with you, because I don't remember where it is, but I have it somewhere with my zero suicide stuff. Anyway, I can't say enough about the safety plan. It's probably one of my favorite things to teach, and my favorite things that folks can do across a system. But you can go to the next.
Yeah, so I would agree. And so when I do a risk assessment, if it is an intermediate, acute or chronic risk, you want to have a safety plan or coping plan, right? We want to identify what that like cue to cope is, right? How we know, right, what the warning signs are. That's why the safety plan is so useful. And then create the plan. So when this happens, I'm going to try this. I'm going to call my friend. I'm going to text. That's self and co-regulating. The PTSD Coach app has a safety plan in it. So you can use both the coping tools that are really awesome in there and the safety plan. And then there's a new safety plan app I think the VA had. There used to be My3, but I think there's a new safety plan app that they just came out with. So you could use that virtually, or you could type it up and send it to clients. There's also a DBT crisis safety plan too that you can include, where it includes more detail. And so you can have them have it printed out, or sometimes people put on their phone to have it just handy. And so I'll shift to the documentation since we're about running out of time for this section. Once you have your risk stratification, you can tailor your interventions and allocate resources really tailored to the client's immediate long-term needs, like immediate and long-term needs with this mitigation plan that we've been talking about. And then you want to document your clinical decision-making, justifying your risk rationalizations, and consult if needed. And only write the mitigation strategies you're actually going to be able to do and willing to do, not ones like you think you should. And so this link here has some blurbs, but when you're writing risk, what might be the first thing that you say? History of suicidal ideation, right? Like suicidal ideation, suicidal and homicidal ideation. And then you might write about suicide attempts, about self-harm, about current suicidal ideation and very specific details about that. And then the risk factors. So have they been hospitalized before, psychiatric hospitalization, past suicide attempt? And then the protective factor. So like maybe a risk factor might be chronic pain or a trauma history. Maybe a protective factor is identifying reasons for living, has dog or children or other people relying on them that they are adamant that they would never act on those thoughts. And then you could even break it down to current assessed risk for harming yourself or harming others if you wanted to break it down even that far. You don't have to though. And then talk about your risk stratification. This person is presently considered to be at blank acute risk for suicide based on these risk and protective factors. Veteran or client is considered to be at blank chronic risk for suicide based on, right? And you'll write those protective and risk factors, maybe a balance of chronic mental health conditions, chronic suicidality, chronic suicide attempt, yet able to maintain safety independently, lots of reasons for living, and that might be an intermediate chronic risk. And then you want to write your intervention or mitigation strategy, did the safety plan, download the safety plan, created a coping plan, follow up with providers, increase frequency to every week, collaborate with other providers, whatever you are able or willing to do that's appropriate and tailored to that. And follow up. So you want to make sure you're following up with that since risk is dynamic and can change, especially we want to look at those psychosocial factors that can change risk level quickly. And then I added a link for documentation of risk. It has some great blurbs you can use. And it also has those risk analysis examples as well. And for suicidality, we're talking about in this next slide ethics, but for suicide and for risk, this is important. And when you're looking at the risk factors and the things you're asking them in this assessment, you're directly assessing lethality. This is someone's life. And so documenting it and documenting it very clearly and saying exactly what happened and being very specific is going to be really, really important as part of your documentation. Even the risk intervention strategies. Client would not agree to reduce access to means, or they agreed to tape all their medicines in a package in 3 different layers with tape and go bury it in the backyard underneath dirt. And that was how we agreed that they would stay safe and agree to come back next week to come in. And they had to engage in that risk reduction in order to be able to come back to treatment, because they can't be in treatment if they can't commit to safety, right? So we're using those behavioral contingencies to really get them to commit to safety. So there's a brief a case example I wanted us to just quickly discuss together when we're looking at these ethical principles. One of the hardest things about the suicide risk assessment for clinicians are weighing these ethical considerations of first, do help and do no harm, and then these pillars of medical ethics, of autonomy, justice, respect, privacy, confidentiality. And one challenge of managing clients with suicidality really arises from these conflicts between what's in the best interest of the patient, or beneficence and non-maleficence, and the rights of the patients to make decisions, right? That shared decision-making model, right? This is the patient's preferences, this is the client's preferences, this is what they prefer. And to make decisions about their own body, autonomy, and the right to make choices about the care they receive, matters of confidentiality, involving other clinicians in their care. And also, like, this is someone's life too, right? So if it's something that you're not quite sure about, right, that would be an important consideration as well. And we'll talk later, we don't want you to worry alone, right? So we're gonna do a brief case example before we take a break and then jump into the full case examples. And we can talk about physician-assisted self-deliverance. Interesting. Towards the end. I'm going to read this case example. Mr. M is a 62-year-old man who has been receiving psychiatric services in the same outpatient clinic for many years. He recently transferred his care to a new physician, Dr. S. Mr. M has a history of bipolar 1 mood disorder. Right? So now you're thinking, okay, is there some like dysregulation, medication issues? His last manic episode was 5 years ago. And over the past year, he struggled with moderate to severe depression. He consumes 3 alcoholic drinks daily, is divorced, is unemployed, and has attempted suicide 3 times in the past. His last attempt was 4 years ago. Mr. M's comorbid conditions include chronic back pain from an old injury, a history of prostate cancer that was treated with surgery, and radiotherapy 2 years ago. At his current visit, Mr. M reports that he's more depressed than usual. He reports anhedonia and amotivation and explains that he's been experiencing trouble getting out of bed and engaging in hobbies. Mr. M also explains that he has been sleeping more than usual and has been feeling guilty about things from his past. He states he no longer wants to continue living and has had thoughts of suicide or thoughts of overdosing on opioid medications. Remember that? Ooh, that's like a big risk factor for suicide. And that he has at his home. He denies any suicidal intent, saying that he's still hopeful that he can get better and that this phase of his life will pass like it has before. He adds that he's looking forward to going to a concert with his friend. So what should Dr. S do at this point? A, should he hospitalize Mr. M? B, should he or she discuss lethal means restriction? C, complete a safety plan or a no harm contract, which we don't have data that no harm contracts are useful. We don't do those anymore. And or D, make review or update a safety plan, or E, answers B and D. What do you all think? Oh, I'm seeing an E. Answers B and D. Lots of E's. So, wow, that was great work, everyone. You're doing excellent at this training. So right, the answer is E, this balance of beneficence and non-maleficence with autonomy and justice. Right, he has elevated suicide risk, right? And we have these past attempts. But we're seeing this lack of intent currently, right? And we're seeing future thinking. We're seeing engaging in going to a concert with his friends, something he's looking forward to in the future. And so risk for suicide is elevated, but does he pose a significant imminent risk to himself? A risk of harm to himself? Right, well, what would you all say? What would be, so it sounds like everyone did E, so discussing lethal means restriction and then completing a safety plan, right? Exactly. So that's that least restrictive method. So we want to go for the least restrictive method. So thank you all for engaging with that case discussion. I'm going to turn it over to Dr. I.
Thanks. So I'm gonna put a resource, another resource in the chat in a second, but this slide is sort of based on the new National Strategy for Suicide Prevention and Action Plan, which it's hot off the presses. It was printed out in June of this year by the Department of Health and Human Services. I'll share it with you in a moment, but really I have three components listed. They actually list about 5, but this slide is just to highlight that it's not, that suicide is not an issue that's only dealt with by psychologists or behavioral health professionals or in a private practice somewhere alone, that it is a community-based, so we're conceptualizing suicide as a public health problem, and that we need community-based approaches with aims to reduce access to lethal means, establish more expansive, collaborative, sustainable partnerships, perhaps like what stakeholders we work with, like if we're, and I'm not a private practitioner, but if we have patients that end up at a certain hospital, do I have relationships with them? Do I have MOUs? Do I have any kind of thing in place where I have some like a shared safety plan or a shared discharge plan, because those pieces are missing, and that's and those are where people fall through cracks. Also with tribal entities and in territorial levels, creating infrastructure so that community like resources like schools are involved. So when our grant, the suicide prevention grant, Zero Suicide, and when we got funding, I immediately included the schools and the community stakeholders in the training. So, I mean, there's nothing like free training, right? And pizza to get people to come. So it was like, we're doing this training. It's really important, and it's to prevent suicide, and it's also to help inform people. And so we invited them and paid for all their trainings with that grant. And I always throw in a plug for postvention. I don't think it's done enough. I don't think it gets enough of a spotlight. And organizations don't address it. I mean, they don't want to a lot of times, but if there's no infrastructure for people, if there's no policy or plan or blueprint for safety, they don't feel safe. And I don't know about anybody on this call, but I've lost colleagues to suicide, and it's a terrible experience. And I think we have to do better at linking everybody in building suicide safer practices. Continuity of care efforts is just like the calls, the caring contacts that we've already discussed. The strategy for suicide prevention by Health and Human Services also suggests or recommends the treatment and the bolstering or creation of treatment and crisis services. And so that's why, I mean, the 988 and the mobile health, there's been a lot of funding in the past few years with the grants from SAMHSA. Also surveillance and quality improvement in research, the timeliness, the scope and usefulness. And then a lot of suicidologists believe, and I'm one of them, that the clinical practice sometimes isn't keeping up with the research, or we're not talking to each other, that we need to build bridges there and be working in real time. And then building health equity in suicide prevention, including peers, making caring contacts, not designating these tasks to other people, like that's your patient, or that's, that we're all sharing these folks and they're part of our community. I'm going to put that I'm gonna put that resource in the chat real quick.
Okay, and while Dr. I does that, I'm going to describe some of that trauma-informed care model that people had asked about. So a new uh, way of approaching clinical work is taking this trauma-informed care approach. I had mentioned the adverse childhood experiences scale, those 10 items. If you get 4 or higher, you've had a lot of adverse child experiences. And those can have been correlated to suicide behavior and those who have died by suicide. And these stressors can really elevate risk. We have this allostatic load, our stress load that our body can hold, and it can't hold any more than that. If there's a little bit over, right? We go, right? We get irritated, emotional. We're like, whoa, well, who was that? That wasn't me, right? Like, so our body can only hold a certain amount of stress, right? With these relational or interpersonal stressors, legal, financial health problems, you want to notice when those psychosocial factors might come up and impact that risk level. So when our nervous system comes on, our experiencing brain, our brainstem comes on and it bypasses our thinking brain. Our central nervous system activation goes into that sympathetic nervous system response. And that needs to be attended to during this brief moment of acute risk. Right? If you're at the emergency room and you're questioning someone and they're getting activated and dysregulated in the secondary fight, flight, response of the sympathetic nervous system, don't block their exit. Right? They're in this automatic response. They're responding in these decontextualized ways, as though they were back in some past learning history scenario. They're not here now. Right? It's decontextualized. And so when that happens, you're thinking, your experiencing brain turns on, your prefrontal cortex is not turned on. You're not thinking clearly or accurately. And so in these periods of emotional distress, when you go 0 to 60 and you get overwhelmed, right? That's the time you really need to pay attention to. That's the time for impulsivity, acting during really short-term emotional crisis. And the crisis tends to happen between 2 minutes and 2 hours, where people can be really distressed and in this dysregulated state. And during that time, when our central nervous system is on, really activated that fight, flight, freeze, fawn mode, that sympathetic activation, the only goals our body has, because great job, our body, right? It's great survival mechanism, it's these survival instincts, right? It's the only goals in that moment is escape, avoid, right? Escape, avoid, all or nothing, right? Like, right, these efforts at control that actually are, right, futile, like they're in this fight, flight, freeze response. And so, and then that becomes too overwhelming and you're struggling, you're fighting, and then, right, like then you're more likely to act impulsively when you're stuck in that dysregulated state and acting from there. And so that's that time period where the increased risk for attempts, right? There's half of these lethal attempts occurred within less than 20 minutes of the person deciding on suicide. So that's why we're seeing this temporal consideration of risk. And so when you're in an emotional crisis, right, it's not just intent that matters, it's that access to means during this time period. And we want to reduce access to means during this time period, just to make sure that you're not acting impulsively and doing something that you could, right, like burying things in the yard, using the gun lock or the gun cable, storing your guns, your ammo separately from your guns. So you want to reduce access to means. So I do means reduction counseling with all my clients. I explain it to them like that. I say when we're emotionally distressed, there's that period where we're not thinking clearly, right? And we might be more likely to act impulsively. And so what might we need to do to reduce any access to means that you have so that we can really protect you from that really important time period? Do we need to, right? And we're thinking back to those original slides, do we need to give your pills to a friend or get pill packs or get a medication package, or do we need to ask your pastor to hold your guns? Do we want to not hold a carry loaded weapon on your body while you're walking around your house? Can we get that distance like Dr. I was describing? And so really this acute risk increases and then decreases over that short period of time. That's when we want to make sure there's reducing access to means and not acting impulsively. And really the goal of safety planning is increasing awareness of those warning signs, those precursors of that suicidal crisis escalation, so we can take action prior to getting to that point. Right. And if they do get to that point, right, then we have a plan and the means are reduced.
Sorry, the chat's so good. I was like, oh, I want to answer this one. I was like, I'll try to get to them. I'm trying to cut and paste them into a document, but this one I just wanted to share something hopeful before I think we have this one, then one more slide, and then we're going to take a brief break, and then we have our last hour. But this slide, if you see the big picture, the one that says "Come back," I will tell you more ways to stay healthy and strong. That's actually pulled from the Chickasaw Nation. They're in Oklahoma, and that is something called it was a caring contact kind of initiative that they had under Zero Suicide. And what they did is they had tribal members and peers kind of sit down and consider what images would be most powerful to share across the tribe. And once, if somebody had a suicidal crisis or even mental health or a family loss or something, they sent them a postcard, and they created it themselves, which was really amazing and really touches me because like some of the tribes actually use their own language in these. These are being done across the country. And I know there's issues with HIPAA but these are like real grassroots kind of ways in which they're engaging, and they're telling people, but we care about you. We're not just here, to get you into these clinical situations. So from a systems perspective, these are quite amazing. And you can find them on the Zero Suicide website. And I also inadvertently, I didn't realize, but the one on the left, it says "We are Native." I don't know if you can make that out. It's not very, pardon my images aren't as clear, but I believe it got started in Portland. And it's it's an online resource. I'll put it in the chat when I find it, but it's usually spelled then "we" and then the letter R, Native. And it's a lot of first person experiences for Indigenous teens. And they have videos on there, and it's really great. And I always give a shout out to Portland for having, started that or funded it. I'm not sure exactly how it got created, but I just wanted to, give you a little image of something positive and these things that are helpful and hopeful. So thanks for letting me share. The next slide will be the last before our quick break. It'll be a really quick break, sorry, and then we'll do the hands-on. But I couldn't not mention the AMSR model. Anybody willing to say that they have heard of this one or haven't heard of this one? It's specific to risk formulation. I call it AMSR for short. It's the Assessment and Management of Suicide Risk. When I worked for Dartmouth, I had everyone trained on this because it was I worked at the inpatient hospital for the state, and I noticed folks weren't really up to date there on their EBP approaches. So AMSR was a very high yield approach. And so they had some like online trainings for different levels, and it's since been updated, but it's really good. It wasn't very expensive. And so I wanted to just bring it to your attention. I'm not going to go through the whole part of it because there's a lot to it, but I really recommend this one. It not only takes into account the long-term, like more chronic factors, it blends in that piece that is missing in a lot of risk formulations, which is the flexibility or the fluidity of real-time changes in one's risk status. And it introduces two components that are important: a risk status and a risk state. And you don't have to use these, but I just wanted to let you know that it's helpful when you're conceptualizing suicide risk and formulating treatment approaches. But risk status is about an individual's risk compared to others, sort of in a stated comparison group. For example, like, and I'm making this name up, Mr. Brown's risk status is similar to other depressed veterans who are receiving care in an outpatient clinical setting. And so it's the risk status, it's sharpening and refining the risk formulation. And I really like it. I think it's great. And if you can get it in a system and you can get that language and that training done, it's really important. I've heard cases discussed in this way, and it's just really elevated my ideas of like what we can do. So risk state is risk state is about time. And so it's an individual's risk kind of compared to a baseline. So Mr. Brown's risk state is the same and or similar to his baseline and is significantly lower than when he was first admitted on our inpatient unit. So again, you don't have to use these, but I would say just look it up and familiarize yourself with it because it's just a way to expand your conceptualization of risk, and it's out there, and it can inform approaches. It also underscores that screening and risk assessment tools aren't enough, that we have to demonstrate the rationale behind our formulation. So I did write up quickly, I wrote up a risk formulation for a patient that I was told by our VA, this person doesn't meet criteria for a flag in her chart for an alert. And I wrote this up, and I still got shot down, but I was like, I'm going to do everything I can to sort of, because I firmly believe this person to be at higher risk, but because she didn't meet the criteria or the parameters by which my system had set up, doesn't mean that she's not on my radar for higher risk. So I just did like a bit of a more extensive write-up. I don't know if anyone's ever interested in all of this. It's a little bit more work than some people are willing to do, but I did want to share that with you. Should we take a 5-minute break and then come back for the last part?
Okay, so that's good. So we'll see you at 12:07. We'll do the case risk formulation practice. See you all then. Thank you. Okay, well, it's 12:08. And while we're waiting for Dr. I was gonna, oh, there's Dr. I. Please, orchid mnemonic. Okay, I'll write the orchid mnemonic and I'll turn it over to Dr. I. Welcome back, everyone. Thank you for joining us in this training, and we're excited to do this last piece of the case examples.
Okay. I think what's the next slide, Dr. Julie? Is this? Okay, we're going to shift. Let's see how the logistics go. We're going to shift. We have two very brief cases. We didn't want to give you too much information for certain reasons, but none of these cases are based on real cases, and all the information's been extremely changed. It's been altered, and it's obviously not identifiable in any way. But what's going to happen, I think, what we'd like you to do is we sent some kind of like group prompts to guide you. So when you get split into these groups, I think you'll be able to turn your cameras on if you want, but just to kind of have one person maybe that could be like the spokesperson or whatever, because when we join back for the big group, we would just like people to be able to tell us, you know, what their group found or what determinations that their group made. We're going to try to do this twice. Let's see. What's the next slide? Okay, these are the prompts. I don't know if I'm going to be able to have like the clinical case up and the prompt. So Dr. Julie, when they get split into groups, will they then be able to see the case? Or I know it's on their PowerPoint, case
Oh,
one.
we forgot to ask this morning. I am not sure. I'll try to paste these questions into the chat at least, so you'll have the questions
Oh,
in the chat
thanks.
for access, and maybe you can see the case. If not, I think someone put the link to the materials and you can open that up and read the case example. We have it in the slides.
Okay. Are we going to put up case one and then split them up, or?
Yeah, let's do that. Let's read the first case and then we'll
Okay.
ask to split up. So the first case is, and Dr. I will read that.
Oh yeah, I'll do the first one. So first case is a troubled young man. His name is Johnny. He's 18 years old. He's a Caucasian male presenting to the ER with a severe arm injury. He was playing baseball earlier. He was accompanied by his parents and his little sister. His family was not present during the initial triage and check-in, and he did disclose, "I haven't been feeling right." He shared that he thought about joining his friend and leaving this place. The
Okay,
clinical,
chat, let's go.
sorry, was our hot mic. The clinical team learns that his best friend died by suicide about 3 weeks ago. And then he's been skipping school, not showering or eating much, isolating from others. He's been disengaged in everything pretty much except for the baseball games. His mom later shared some recent disturbing posts about death and dying on social media on his accounts. And he has a history of moderate depression, never really been treated. His father is a police officer and thinks he's just being weak-minded. And your role as a group is you're the behavioral health consult to the ER. So you're in an on-call capacity, and you're going to provide recommendations and come up with a working risk formulation together. So we're going to separate for like 10, maybe 10 minutes, 9 to 10 minutes. It's not a lot of time, sorry. And then we'll bring you back for a larger group, for a brief larger group discussion, right? Just follow the prompts that were on the screen before that. Did you paste them into the? Sorry.
I think Taylor's going to move everyone now, and
Just give me one moment here while I get everybody into the room.
Are we in?
Are we in our group?
It's just taking a
so.
moment. Sorry about that. It'll just take here a few minutes, but I'll move you over. Give me 60 seconds.
I'm here.
I'm here as well.
Hello.
Hi.
Wow, this is an enormous group.
Uh-oh.
She said she was going to post the questions in the group chat, but I don't see them here.
Don't either.
We could start talking. Just this is a real concerning case, I would say. Talking just this is a real concerning case, I would say.
There's like 43 participants and it keeps decreasing. So I don't know if this is the final group.
Okay.
Oh, wow, that's a big group. Okay.
Oh, yeah.
I think they're still splitting us up.
Okay.
Okay, I think we'll leave this group here. And we can go ahead and start. Thank you for that patience.
Are in our group?
I have no clue.
Yes,
I guess so.
we're leaving you guys in this group. Yep.
Okay.
So I mean, I guess we could just go through the questions. It looks like the first question is your patient / client at risk for suicide?
I would say
So,
yes.
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 With a prior, like a friend who died by suicide about 3 weeks previously, that's an indicator of risk. And then I don't know what else was in the prompt.
The social media posts about dying. So he's obviously having thoughts about it.
Right.
The only thing he's been doing is going to baseball, but basically everything else he's not doing. But then he injured his arm today, so that's going to be an actual increase.
Mm-hmm.
Mhm.
Yeah.
Plus, he's a white male who's 18, so
And I'm not sure if this is an assumption or not, but with a parent who's a police officer, I'd be concerned about firearms in the home.
Yes.
Yes. Would want to know about would want to know more about lethal means and if they were going to be sending him home with pain medication.
mhm.
And I think the potential for his feeling shamed by his father
Yes.
high.
Also, the fact that he has no mental health history treatment wise whatsoever. So no allies, no therapist. And then it also sounds like what has possibly been an ongoing kind of moderate depression. It sounds like that is now all exacerbated in light of what happened.
Yeah. They don't mention anything about substance use, but I would wonder and probably ask at the same time.
You're muted.
I would ask about other peers and a support system outside of the family.
Judith, you muted.
I would be curious about what his feelings of self-esteem are. And of inadequacy, it seems like he may not feel very good and strong about himself, particularly if he compares himself to his father.
I'm curious about protective factors. So, what is relationship with mom and little sister like? Are there other peers that he does connect with? Does he have any online friends?
Teammates.
Teammates for sure.
Yeah, just based on this description, there's like not any protective factors, at least listed.
Yeah.
Very few.
Though, the teamwork thing is, he is to find out more about his relationship to his baseball, because that is a team sport, and may have connections with his particular community. He may have, may be able to identify in a positive way with that sport.
And coach maybe, depending on kind of what the dynamic is there as a protective adult.
But he may be losing that due to his arm injury. So another loss.
So what kind of physical therapy or other support does he need to help in his healing process with his arm? And what other activities might he also become aware of that he might want to engage in?
I also wonder, like sometimes, with team situations like this, you can still attend practices and, like just be part of the group and maybe not actually be engaging in all of the exercises. So that might be a question for the medical providers about like, to what extent is he still able to engage in activity so that this protective factor isn't fully like taken away.
I would also want to be mindful about like immediate. I think that's such a great idea, but thinking about long term, he's 18. The season might be coming to an end. So kind of what longer term things, even though obviously we're dealing with the immediate, but what is his support looking like after baseball season, regardless of injury?
And because of the injury, is there any possible positive relationships with any of the people in the healthcare system that he has had to access?
I also want to be very direct about like, okay, have you engaged in any planning, any research around how you might want to die or take those steps? To be upfront about like gathering that risk assessment. At least based on the prompt, even though he's made statements, they've been passive statements. Not feeling right, recent disturbing posts about death and dying. So I'd want to get some concrete information about level of risk.
Which I think addresses number 3 on the list of prompts, which is basically would we want to use some kind of a screen point or an assessment tool, just based on the fact that there are so many risk factors present. I think that's a pretty obvious yes, we would.
I would want to know what has created his disengagement in everything except ball, and how he might get re-engaged in some of the other activities at school or in his life in general.
I think getting some information about his spiritual beliefs, how to the extent to which he thinks he's going to join his friend. would be important to understand any spiritual beliefs about suicide, any potential protective factors there.
And we do have everybody in this main room, Dr. Julie.
Okay, wonderful. Thank you. I believe Dr. I typed into the chat the questions that
Did they
we
get in
wanted.
there? I wasn't sure if they were getting in the main chat, or I tried to type the prompts in again. Did it get in there? No.
I don't see them.
Oh, so they're probably in
I saw
random
it.
breakout rooms that I was in.
I saw 'em.
At one point it logged me out. I don't know.
Yeah, and I have to pull up the PowerPoint. Do you mind leading the discussion briefly, Dr. I?
Oh, no, no worries, no worries. And this is really for everybody to discuss. But with that first case, and considering your role, like you're on call, you have to go into the ER and you're meeting with this person the first time, just, jump in. But do you think this person, was Johnny at risk for suicide? Yes or no? Does anybody want to jump in?
Yes.
Yes.
Yeah.
Yeah, he was, right?
Yes, he was.
And why do we think that? Why did your group think that?
Recency of his friend's suicide. We don't know his indigenous roots. That'd be crucial to know. It's much more crucial in indigenous families. Number 3, his dad's a cop. Number 4, potential access to weapons because his dad is a cop. Number 5 is getting messages from his dad that he's a wimp if he talks about this stuff. Number 6, we don't know if he knows as an 18-year-old, he has right to medical care and mental health care independent of his family. Number 6, we don't know about social contacts beyond his friend and apparently his younger sister who came with him to the hospital.
Great. Right, and off the get to his demographic group, right? And I'm glad you
Yes.
said that about the access, because that's kids die in homes when they have access to lethal means.
Right.
And that's what happened.
One thing I didn't mention is that we didn't know anything about the injury. How did that happen? Was it self-inflicted? Was it part of doing something, but it actually was self-inflicted as part of a wish for self-harm?
Right, like putting himself in harm's way or acting in a reckless manner, which is also
risky behavior.
indicative. Yeah. Did anybody come up with, it's really hard. It's such a hard task to do together really quickly. So we appreciate your willingness to be in the rapid fire, no pun intended, sorry. Use of an EBP screen or assessment tool. Did anybody use anything that was evidence-based or informed?
Would have used it while charting, while talking with him.
Yeah. And which one specifically? Did anybody gravitate towards anything? Columbia.
The Columbia.
Yeah. And if you go on the Columbia Lighthouse website on their homepage, you scroll down, there's it's free, and there's all these iterations. There's actually one for athletes and one for coaches. And it's really interesting how specific they get. Was someone going to say something? I'm sorry.
We just had a suicide last year of an athlete in the high school. And I just went, because there had been 2 other suicides of teenagers in the same community within the same year in Hood River. And so people were shocked that an athlete would commit suicide compared to the other folks.
Right.
I just should mute myself.
And athletes can be at particular risk because they're supposed to be performing. They're not supposed to be suicidal. They're supposed to suck it up. And there's been a lot of literature about that, especially college athletics. And it's always worrisome when there's more than one, right? And we start to see these patterns, or we call them contagion sometimes. risk level, what did you think he was?
Acute.
Acute? Did anybody think anything differently?
Intermediate to high risk.
I think
That's-
it also would have been helpful to have a little bit more assessment about whether there was active planning involved. At least based on the prompt, a lot of the ideation that was reported was passive, or I think you used a different word for it that I need to start integrating.
Well, it's hard because like if
Talked
Johnny
about morbid cognitions,
Morbid
right?
cognition, right.
That's
Yes.
a way to distinguish right between. Okay. Sorry for interrupting, Dr.
Oh no, that's okay. Sorry. And it's hard because I think I forgot. You know what? I totally had just like a ADHD moment. I'm sorry.
I brought it back to the case on the screen just in case we wanted to look at that as we're talking about it.
Oh, I know. It's hard because I know there's active and passive, and we say that, but we don't really. But if Johnny's like, I'll just use these terms quickly, but an internalizer or doesn't have a lot of language around this, and he's not endorsing it, but then come to find out he's been thinking about it for 3 weeks straight, like all day, very intense, like 10 out of 10, can't push the thoughts away, so lacks control. So there's frequency, intensity, and controllability are the primary kind of pieces of that. That's a problem. So somebody can be coming in and explicitly state, suicide, I have a plan, but this person is, there's a lot of literature about this. This person, this quiet person with this silent suffering, intensity, frequency, lack of controllability is also at an equally high risk. Let's do the next prompt because I know we have one more case that's a little spicier. Next steps, did anybody come up with any dispo or recommendations? I heard some really good conversations accidentally. I was in different groups, but anybody or prevention considerations and challenges? What else?
We wanted to know about access and means, and that would really determine if his dad's a police officer, there likely is a firearm in the home, and can is that locked up? Is there a way to prevent access to a firearm?
Exactly.
I think his father's, of course, languaging around being weak-minded is really off-putting, I'm sure, to a lot of us. But I wonder about finding a way to find some kind of alliance with parents, family, and talking about, how do we build sturdiness? How do we build strength? And so it's not just that idea of he's weak-minded.
Whoever's talking, fantastic, right? Because I even thought, like, I wonder if like a family, they don't have to go to family therapy forever, but how helpful would that maybe be to have a couple sessions to build, like what you just said was fantastic.
And
Other
also,
thoughts?
you're considering two cultural considerations, right? If we see sometimes in Hispanic families, there's this stigma against mental health treatment. So I had one client when I was first a grad student, right, talking to me about putting a shotgun in their mouth and pulling the trigger, and that their dad thought the same thing, right? Like that mental health, that you're crazy. Or I just sat there kind of calmly. I'm a trainee, like for the first time in grad school, like sitting there, asking very calmly, right? And then afterwards, like, thank you for sitting there and holding that for me. And they engaged and cared. I would see them running down and doing their behavioral activation down the street when I would be driving by and see them. And so it's really important, right, to really consider these like cultural considerations and looking at like stigma and how to reduce stigma to increase access to care in different groups. So great point, Drew. Thank you so much.
Well, I'd like to add one thing in there too about this. I think it's important to look at the question of whether this is a grief response before we go all the way to this is a mental health problem. Is this a question of normal grieving? Is this a child who's grieving, who looks depressed? That's also, of course, part of the reframing of it, and maybe one of the entrees around resistance from the family, if such exists, that this is a child who's dealing with the death of a friend. We don't know enough about the closeness. And I think that's really important when we're doing things to not pathologize normal reactions such as grief.
Right.
And sit with those primary emotions and validate that primary emotion of loss, right? And really sit with that and target that. Yeah, that makes sense.
Well, and I also think it's one of the ways around. I think we don't deal well with death in this country, and we sometimes pathologize normal reactions like grieving. And that's an important issue. Is this a child who has a mental health problem at all? And not Jogo jumping the gun and cast this as you need therapy, as opposed to you need to do what people do when they grieve and they lose somebody. Because it's only 3 weeks. We don't know how close he is to this person. We don't know if there's more support within the family structure for your grieving. This is what happens to life. You're dealing with an important part of life, dealing with the loss of it.
Mm-hmm.
Not immediately assuming this is a therapy problem.
That's an important psychosocial risk factor too, right? This a loss, right? I mean, that's might impact that risk too. Any other comments before we shift to the next case?
Just that we discuss a few of the mitigating supportive relationships that might be explored. You know, one would be his teammates. Are they from baseball is a team sport? Are there people that he feels close to there? Of course, people within his family, like his sister and his mother, that have shown up for him. And someone else brought in the potential spiritual religious beliefs about that may be supportive of him, and just to be able to sort of explore, and even possibly the medical team that helped him with his arm. There may be somebody he connects with in that group, or the physical therapist, or somebody that can be part of that community.
Good going, Kate.
Well, and we have some chats about suicide's prevalent among law enforcement, and would wonder if the father had any colleagues who died by suicide, and that could be a way to connect.
There was a group too that was talking about pain, and like, I think they said, would this kid be getting any medication? What, it was there, and also the perceived burdensomeness. There's a lot more, and we left out information on purpose, but it sort of shows you how complicated, and it just gets really complex really fast, right?
So I think we have about 10 minutes left before we wanted to shift to questions. The last 15 minutes. I know we were thinking of doing a breakout room for the last case, but I don't know if we'll have enough time to do that and discuss it. So maybe we want to, I don't know, what are people thinking? Do we want to?
Should we just put the second case up there and then just talk about it as a big group? Would that be easier?
Yes, I think that would be great. So do you want to read the case, Dr. I?
I will.
Can I just jump in on one thing that I wanted to say about the last case? And that is, I think before he was discharged, it might be good to have a conversation with the family about the contagion aspect of suicide. And that might also help the dad feel less defensive about his son having suicidal thoughts, and not think like, oh, he's crazy, but this is a phenomenon that happens a lot with kids.
Absolutely. I can't see your name or who's talking, but spot on. I think you're spot on. Jump into the second case, or I feel like there's always so much, and I'll jump into the second case because the second case, I do have an outcome for this one. So it's called My Mom Went to Italy Without Me, 26-year-old Caucasian cisgender female. She's presenting for kind of like a crisis appointment in outpatient. She has her psychiatrist and her psychologist sitting with her. Her father contacted the clinical team in the morning because she was seen at the CPEP about 24 hours ago. However, they did not admit her. They didn't deem her to be acute enough risk. Her father's really still concerned about her safety. He's been watching her since that visit. The patient has a history of suicide 3 times the past 1.5 years. She's had 2 subsequent psychiatric admissions. She has an extensive history of depression and eating disorder behaviors and diagnoses. She has a significant history of non-suicidal self-injurious behaviors. She has been cutting, but not too deeply, but for many years. Stopped about a year ago. The family has no lethal means at their home. the patient has repeatedly stated she doesn't have any current plans or intent to die by suicide. She's acknowledged frequent, persistent, difficult to control. There's a theme here, thoughts of suicide. And we asked her, when was it most intense? When were these thoughts the most intense? And she said, this morning. She is also an engineering graduate student and had a breakup with her boyfriend about 3 months ago. Your role is the outpatient psychologist. We'll leave the case up there and we'll just ask you the prompt so anybody can jump in, and Dr. Julie and I will both talk with you. First question, is she at risk for suicide?
Yes.
Heck yes. Yeah. Absolutely, right? But she's saying, she's denying the explicitness of it, but we know now there's a contextuality to it, right? Who wants to list I mean, the warning signs are pretty endless here, right? Or the risk factors, and any warning signs versus risk factors. The challenge question.
Well, her most intense suicidal ideation has been this morning. So I don't know if you would add that.
Yeah,
Yes.
absolutely. Absolutely.
And dad's concern.
And he knows her, right?
Yeah.
It's like, she's got a history. Yeah. Would you use any screening tools in this case? Or maybe we have enough information, like, or maybe we don't. I don't know.
Well, actually, it was her father that made the contact, not her.
Mhm.
So we don't really know about her.
He made the contact after the CPEP visit, right?
Didn't he make the contact? Wasn't that the reason for the visit?
Well, yes, but it was like it's sort of linked to the recent CPEP visit, and she has like an established care with the psychologist and the psychiatrist. So he's part of, I guess I'm assuming he's part of her treatment, or part of her allowed to be part of her treatment. Is that what you?
I'm a little lost about what the CPEP stands for.
Oh, sorry. It's a I'm sorry. I always say that, and it's different in different states. It's a psychiatric emergency room. So instead of just going to like a general ER, like New York has this, we call it the CPEP in New York. It's just it's for psychiatric emergencies. I'm sorry. I forget.
I think what Hank is pointing out is that it's not clear from the description that the psychologist has actually talked directly to this patient today. Maybe he has, or she has, or they have, but that's the next thing. That's why maybe a suicide screener with this person would be a good next step to really clarify the information, since it almost seems from this that it's the father who's providing the information.
Well, I think it might be helpful too to clarify our role. If we're the outpatient psychologist, do we have an ongoing relationship, or is this a first contact? If it's ongoing, have we done a suicide assessment in the past? Sort of just where are we in the journey? Is this our first contact with her?
So yeah, sorry about that. So just to clarify, you are her psychologist. So so there's an established care, but we left out certain pieces of information, such as, was there a suicide assessment done in the past? Because we know we don't even know if that was the same psychologist as when she was in the hospital, right? But what else is missing? What else would you want to know? Because those are good points.
I'm confused. Did her psychologist and her psychiatrist bring her to the ER? Because it says she came to crisis appointment with her psychiatrist and psychologist. So I think that's just confusing people.
Oh, I'm sorry. She went to the CPEP 24 hours ago. Her dad called for a safety check with her established providers, one of which is you. So she went to CPEP and they didn't admit her. Dad's still worried, called her psychologist, who's you, and psychiatrist, and they had like an emergency meeting. I'm sorry. Yeah. But good to clarify. Any other information that's missing for people here?
I think understanding what the suicidal thoughts sound like. I understand she has no intent. It sounds like there's not any like apparent means, but are there situations where you're tempted by those thoughts, like crashing your car, right? That doesn't seem like a lethal mean right away, but it certainly can be. And so I'd be curious about, like, even though there's no plan, what do the thoughts sound like? Does it sound like all of a sudden crashing your car when you're really distressed?
Good. Like, how intense does it get? What would anyone want to know how she's attempted in the past?
Absolutely.
Absolutely.
Right. If it was
We had
an aborted.
some of that in the chat where they wanted to know what were some warning signs before. Yeah, that's a great point.
And how quickly did it, did she go from not suicidal to attempting in the past? Because some people like this, I've seen, they literally, I mean, as you say, many successful suicides occur within 20 minutes of thinking about it.
Right.
1 in 5, and within 10 minutes of not even planning, right, to thinking on it. So that's a really important point that she's right. There's some indirect warning signs, right? And we're getting some collateral reports, and now we have some screens, right? Some more objective data and our clinical impressions and interview. And so we're noticing this picture. What level of risk do you think you would classify her for acute risk?
High.
High.
Well, intermediate to high, because she's saying she doesn't have an intent, but I'd want to probe that a little more.
I wonder what are the differences between her from 24 hours ago when the emergency room didn't keep her, but here it is in the morning the next day. What has happened since then?
And we're also seeing in the chat impulsivity, eating disorder status, right? Is there likelihood to asphyxiate, right? If you're purging, impulsivity in action of that, could it be impulsive and lethal?
Also, even if she's not reporting a desire or intent to commit suicide in the office right now, I'd really want to know if that is different when she has the frequent thoughts of suicide that come up. Does she have a desire to commit suicide when those thoughts happen, even if she doesn't currently in our office? Because if that's a pattern, then I think that would definitely increase her risk and change the plan for coping and maintaining safety.
I'd like to know how often she has hidden from the person she's working with her actual intent. Does she have a history of saying, I don't intend to harm myself when I do intend to harm myself?
I'd want to know a little bit more, or assess more around the functionality piece around the suicide attempts, and even what was it like for her to not get admitted? Was that really invalidating was it really invalidating to her suffering? And yeah, to kind of get more of a, what is the function maybe of the number of attempts that she has had?
Right, is it functioning to get maybe like care or attention, and maybe she's not getting that? Someone had mentioned shamed before, right? Can we notice the precursors and intervene with compassion before we get to that shame spiral? Right, what was happening immediately before those suicidal thoughts that she was having earlier this morning?
That was what I was thinking, particularly if you have a relationship with her anyway. It struck me where I work, we use the Columbia, and she would be considered a high risk for like the next year after what had been going on like a month ago. Not that that matters in terms of how we're going to approach it clinically so much, but I would want to do something along the lines of a chain analysis if she had the ability to do it from the leaving the ER last night until this morning, what made it worse, And if I knew the way that she tended to work with different triggers and her coping skills and responses, I'd want to see if she tried those or not. If she was motivated to try those, didn't want to use them because she's feeling hopeless or a burden or whatever. Or if she tried them and they didn't provide any relief, or if discussing them helps her feel more in control.
Those are really great
I'd
points.
I'd really want to know how on her last 3 suicide attempts, how did she end up in the hospital? Did she call in or did we find her? I mean, obviously she's got a lot of borderline characteristics, and we want to make sure that that psychiatric hospitalization is going to be helpful to her, or whether something more outpatient and coping skills is going to work for her.
Something along the line, I think that Drew was speaking about, her thoughts are more frequent and difficult to control and more intense this morning. But I would also like to know her relationship to her thoughts. Does she find herself less in a sense of controlling her hands and arms and feet and mouth, even though the thoughts are there and more intense? Or does she still have a sense of, I have a lot of control over what I do with my body, even when these thoughts are present?
Focus on control, are we dissociating or not, right? Like what, and right, is this like maybe acute psychosis and maybe medication and not, and and hospitalization might be appropriate if it was an intermediate level of risk, right? I know someone was going to say something, so let's take one more comment and then we'll switch to questions.
I was going to mention it also probably would be worthwhile reaching out to the ER. I used to work in a system where they wouldn't admit people if they denied intent, and I would literally have to call back and say, yes, she's denying intent. That could change in 5 minutes. You need to reassess, and sometimes it's if my clinical judgment was that the person was really at acute risk, it required a lot of advocating, because I get people who say, well, she said she wasn't suicidal.
It does reflect our I just typed it out because I didn't want to forget, but our over-reliance on patient self-report. And also she's been hospitalized before for this. Well, that's kind of what I implied, but she's been hospitalized before and she knows, and I'm not saying that she's doing this, for any particular reason, I don't mean to imply, but she knows what's going to happen if she says, yes, I definitely want to die today. She knows what's going to happen, right? So this case was based semi-loosely on a case where this student stole something from her boyfriend's lab in chemistry and died and ended up dying by suicide that evening, despite sitting for like almost 2 hours and talking to her established care providers and telling them no and telling her dad. It's like we have this over-reliance, this sort of bias on what patients are going to tell us. And then it renders us like, what can I do then? Because this is all I can do, right? But it's just to give you a point. And because of time, we're going to segue to like some Q&A. I know we have like 9 minutes left, but thank you, everybody. Great points. I know it's kind of rapid fire. Poll question: what's something you'll take with you to implement or hold in mind, something that you learned today that was helpful or useful, that you can use in your practice? And then if there's any questions, we probably have not a lot of time, but we have some time. And then hopefully you have our contact information if you want to get a hold of us. I owe someone something, a little statistic or research. I'll send it to you if you send me your email.
And so for the lifeline, it's been shifted to 988, right? 911's you call the emergency 988. You can now call or text when you're in emotional crisis. So we want to open up for questions at the end. Thank you all so much. If you could let us know what your takeaway was from today that you will take with you to bring with you so we could see what was the most impactful or effective. We really appreciate all of your participation. You've been a wonderful group today. Thank you so much for attending. I know that Drew was collecting some questions that maybe we might want to jump into.
I'm just pulling up some of the questions I got. You listed alcohol and substance abuse, but didn't include behavioral addictions such as gambling. I think this is when we were talking about risk factors. But yeah, would things more, I guess, behavioral addictions such as gambling be a risk factor?
Oh, I'm going to interrupt before we answer that question because I'm noticing there's about 6 minutes left and participants are asking about their code for the CE. And I want to make sure you all get your credits for this because this has been 4 hours of really hard work that you've all been really great at. So I think that there's a code that Drew might give us.
Yes, I will put that into the chat. And the code is turkey. I think many of us will be eating later this November. And I just put it into the chat. Oh.
Okay, so turkey, all caps, you'll get your assessment. Thank you all so much. I know that there were some questions about physician-assisted death and physician-assisted dying. And I know that, or no, Dr. Ive, was there something else?
I think Drew was reading a question, but I lost the question. It was about alcohol or addiction or something.
Oh,
Yeah, I think the question was around, it was when we were talking about, so I think some risk factors, mentioning alcohol and substance, or yeah, alcohol, and other substances, but would behavioral addictions such as gambling be a risk factor to consider in assessing risk? Or is there any research on that, I suppose?
I know there's research on that. I think the alcohol and the substance stuff tends to be higher and more aligned with what we conceptualize as suicide because of the recklessness or the disinhibition. And there's a whole slew of things I could say about that. More likely aligned versus gambling. However, that being said, there are some characteristics that are aligned with like a suicidality, a profile of suicidality in which folks are having more challenges around controlling behaviors. And so but I don't have a specific resource for you, but that's a great question. There's been a lot of thoughtful questions, by the way. One more question. Do we have time? Or what time is it?
What was the stat for people who had seen their primary care provider or a medical provider and when they suicided? Or
I can send that to you, but it's on the Zero Suicide website. It's I think it's like 45% or 47 or 40. It's in the 40s. They have let's say over 40% of people that die by suicide have seen a medical provider or like a physician or it's usually a primary care person within 30 days of dying by suicide.
Okay.
Yeah.
Thank you.
Yeah.
I don't have any other questions that I wrote down. I think you actually answered a lot of them in the chat or in the presentation. So I suppose if other people have questions to ask them now.
There was a really thoughtful question about what are some good questions to ask yourself to evaluate personal bias around suicide. I was going to give that back to the group, but I was thinking about beliefs and attitudes. Like I've seen a lot of shame with clinicians that lost a patient to suicide. And then they were sort of like, they were very much more risk aversive in a public health setting or like sort of, well, I can handle it. There was such a reaction around that. It was really challenging to get people just to sit at the table and say, this is really hard. Let's start having some challenging case meetings or high risk meetings to do something together to make some recommendations, like beliefs around what we can and can't handle. And then personal experiences, like also our bias towards people that can verbalize their explicit risk. Like, what am I not hearing? I don't know if anyone has any ideas. I really love that question. Sorry, I just took over a sec.
Oh, and then someone had talked about physician assisted, I guess now it's called self-deliverance. It's had lots of different names, the Oregon Death with Dignity Act. We looked at some interviews in when it first came about, and we're seeing these instances of this, like a lack of not wanting to have to suffer or not want to lose their autonomy towards the end. And so you qualify for that 6 months for after having a terminal diagnosis, which sometimes is tricky, right? Because if you have dementia, and are you able to even consent to that, right, by the time that you get to it? And there is also that suicide booth in Switzerland that they just came out, right? And so sometimes I've noticed some people talk about like having the right to die, right? Which is like kind of this existential issue. And but it's like mood and depression. It's like, oh, gotta take those lenses off. That's a con, right? Like it's that con that's kind of like keeping us stuck in those negative emotions. And like, right, there's that like existential autonomy piece of, do people have that, right? And is that something, if there's like this burden of suffering that they might want to engage in, but taking that as part of your assessment, how is that functioning as they're thinking about, that? But I wasn't quite sure exactly what you wanted about physician assistant tests. So please reach out if you have any other questions. I know we're like at time. So thank you all. Thank you to the Oregon Psychological Association. Thank you, Dr. I, for coming today and sharing your expertise.
Thank you.
And thank all of you. We really appreciated you here today.
Thank you.
Yeah, thank you both. We really appreciate this presentation and the expertise that both of you have provided to us today. And the survey will be sent to everyone. Please complete or put in the verification code, Turkey, and we will verify names and everything. And your CE credits will be sent to you within, I believe it's the next 2 weeks or so.
Okay, great. Thank you all. Thank you so much. Take
Bye.
care. Bye.